Call to order the, whatever this is, the Project Review Committee for the Behavioral Health Services Advisory Council. We'll start off with OMH today, unless there's a huge objection for Oasis and a cash bribe.
No.
Seeing neither, let's start with the U of R CPAR 20. Keith, take it away.
Okay, the University of Rochester Medical Center, Strong Memorial Hospital, otherwise known as URMC, is requesting approval for a cap.
Time out just for a second. Is the applicant in a room? I'm guessing, yes. Okay, thank you. Yep, we swap. We're good.
Okay. They are requesting approval for a capital project to construct a facility that will house 2 outpatient programs currently licensed by OMH. The Adolescent Partial Hospitalization Program and Strong Memorial Child and Adolescent Clinic, both located in Rochester. In addition to operating Strong Memorial Hospital and Article 28 General Hospital, URMC also operates a 93-bed psychiatric inpatient unit, a comprehensive psychiatric emergency program, 2 partial hospitalization programs, 2 ACT programs, and 2 clinic treatment programs. All are OMH licensed and serve the greater Rochester area. URMC has identified an increased demand for outpatient services. Its clinics currently have a wait list of over 300 individuals in need of services, and the partial hospitalization program's wait list is 87. The new facility will allow the provision of services in less cramped space and allow the programs to expand to serve more of the mentally ill population in this region. Soon after completion of construction and the clinic and partial hospitalization program are relocated to the new facility, URMC will reassess its capacity to increase volume and submit EasyPAR applications to expand the services provided by these programs. In addition to the hospital's capital funding, URMC raised funding from private donations to help address the needs identified for these outpatient programs. OMH is recommending approval.
Okay. Any committee members with any questions for the applicant or the department?
No.
Ralph?
So has the $5 million in donations already been raised?
Yes.
Okay, congratulations.
Yeah. You got $5 million specifically for expanding mental health services?
Yeah, from town council.
Okay.
Oh, okay.
Well, thank you for us. I mean, it's hard to raise money, for mental health and substance abuse, so I'm just very impressed, and that's very helpful. So those revenues, it's based on that revenue, I mean, it's what you're paying, how you're paying for it. That's not your own. He's not giving $5 million a year to run psychiatry, I guess.
Right, he's just paying for the
Got it. Yeah, so it's a one shot, it's not a revenue stream that's going forward. Okay. All right, and we have all the field office, people are happy, they'll go look at it at the appropriate times and all of that, but.
Yes.
And local government type people are thrilled, I assume? You didn't
Yes.
see the paperwork with it, but, yeah, we got approvals, conditions, approvals, et cetera, et cetera. Everyone's happy, or will be, cool. Any other questions for either the applicant or the department? Seeing none, we'll do it as a positive motion to recommend approval to the full council later this afternoon. Any further discussion? Seeing none, let's vote. All those in favor?
Aye.
Thank you. All right, so we'll give a favorable, unanimous recommendation later on this afternoon. Moving on to project number 182044 in Oswego County, Oswego Hospital, a capital project. Keith?
Yes, sir. Oswego Hospital, Inc. requests approval likewise for a capital improvement project to construct a facility where we'll relocate an OMH certified clinic treatment program for adults and a 28-bed psychiatric inpatient unit for adults, and to increase their inpatient bed capacity for the psychiatric unit to 32. The proposed new location is less than 2 miles from its current location at 74 Bunner Street in Oswego. The proposed project involves a complete reconstruction of a 42,000 square foot, 1-story building that has been vacant for several years. Upon completion, the move will occur in 1 day with no cessation of operations. The project is expected to be completed within 24 months. Oswego Hospital has been awarded a statewide healthcare facility transformation program grant in the amount of $13,023,850 for its plan to transform itself into a financially sustainable institution capable of preserving and enhancing essential healthcare services. Over the last decade, the current facility has been unable to adequately serve the needs of inpatient and outpatient recipients of services for 2 primary reasons. First, the 21,000 square foot facility is roughly half the size necessary to serve the needs of the patients in the inpatient unit with appropriate follow-up care. Secondly, the facility's decay and functional obsolescence create an unwelcoming care environment for which both psychiatry staff and patients have expressed dissatisfaction. The inpatient unit has been operating at maximum capacity with utilization rates ranging between 89% and 100%. Oswego Hospital identifies this project as key for it to succeed with its transformation plan, particularly as it will significantly improve the financial health and long-term financial stability of the hospital. Behavioral health services have been the greatest source of losses to Oswego Hospital, creating a deficit of approximately $2.5 million toward the hospital's net deficit over the last 5 years. With the support of DOH and OMH, Oswego Hospital received a 3-year, $3 million VAP grant to allow the continuation of behavioral health services. This interim support has allowed the hospital to manage the transition to reorganizing services and improve patient and client utilization of these services until this capital transformation could take place. OMH is recommending approval.
Is the applicant available?
Yep, they are here.
Okay. I know there are going to be questions, so do you want to introduce yourself, Alan?
Sure, I'm Jeff Coakley, the Chief Operating Officer of Oswego Hospital.
I'm Dr. Mandanas. I'm Chief Medical Officer of Oswego Hospital.
Okay. And is there a third person there, or am I?
Nope, you see Bill.
That's me going.
Got it, thanks. Okay. Okay, welcome. I know I have a few questions, but let other council members start. Or committee members start. Anyone have any particular questions?
I think you'll probably cover them, but I'd like to hear a little bit about the financial transformational plan.
Right, so, I mean, I think many of us have looked at these numbers and are concerned, also confused. So this project is to build a building for programs that you're projecting are going to lose over, what, $2.5 million a year or more going forward, or at least the first year. Yet you got $3 million, which would seem to be $1 million a year, but you're only losing $500,000 a year to the debt, is what it says. So I don't understand how that works. And I, quite honestly, I think the viability of this entire project financially is a major concern. So those are sort of voicing some of them. If you could like just answer any way you think is the most appropriate and helpful for us, would be a good place to start.
Sure, let me reflect on where we've been over the last several years. This journey actually started in 2011 because we were in a facility that, quite frankly, doesn't function well for clients and patients or the providers utilizing that service to support them. So we know that there's a level of functional obsolescence there that needs to be addressed. We need to replace the facility. We know that. We've asked the Department of Health as well as OMH over the last several years to support us in interim measures. We've looked at a number of ways to do that. We appreciate that support from both OMH and DOH. I think that's allowed us to get to a position where we could build a plan within that grant application that supports the continuation and really the sustainability of behavioral health services in our community in Oswego. That plan really includes developing other services within the entire health care system. So to support the project within that grant application, that plan is key. So we need to continue to develop volume and resources within the healthcare system that are going to offset the costs of providing this mission-driven service for Oswego Health in the future. So for us, it's more than just providing behavioral services. This is an integral part of our community. There's a significant need in our community related to behavioral health services. We have nearly twice the level of suicide than the state average. We are ranked annually by the Robert Wood Johnson Foundation, the University of Wisconsin study on counties, equal to or maybe even worse than the Bronx when it comes to the level of health status, and in particular, positive behavioral health days in our community or negative behavioral health days for our citizens rank very high. So we've got a significant demand and need. The socioeconomics in our county have certainly a strong role to play there, and we want to continue to develop and retain and maintain this service for generations to come. And we think that plan supporting that is going to allow us to create sustainable behavioral health services. So we've acted on that plan. We've developed wound care services. We've developed a bariatric surgery program. We've developed additional inpatient and outpatient services. We've had an increase of $800,000 in revenue over the last month related to those services. We know we need to grow out of that challenge of sustaining behavioral health as part of the mission of the organization. We appreciate the Department of Health's recognition of this challenge, that recognition coming in a $13 million grant. Our board also recognizes the challenge. They've come forward and increased their matching funds from $1.5 million to $4 million to truly build the center that we have before you today for approval. That center not only includes 32 beds of inpatient adult, it includes an expansion of outpatient behavioral health services. It includes the integration of primary care services for this community. For the first time really in our community, we'll be able to do that. It also allows our case managers and care coordinators to join us in that facility for this population that need that level of support. So that's some background addressing a number of issues. I hope that answers some of those questions.
Yeah, and I can add for the committee members that, you know, the VAT monies, and they literally stand for Vital Access Provider Funding, has been used by OMH and DOH over the past few years, particularly for those hospitals in the most remote areas of the state, of which Oswego Hospital is one. And they are meant to bridge them to improvements into other capital and transformation initiatives. So whereas I know the committee is aware, we've had other applications from such areas that have either proposed closing or downsizing their units. We're supportive of Oswego in this situation where they're actually adding beds.
So if I can ask, I don't know if the applicant has what we're looking at, Keith?
No, they do not.
But
it's based on the material they submitted to us.
Right.
All right, then there seems to be, I think I may have been reacting to a typo now that I look a little bit more carefully, because under their revenues, they're booking almost 2.5 of Medicare, but on the top of it, they're showing first-year revenue at less than they're talking 300,000. So if the revenue is missing a comma.
Yeah, that I'm guessing that it would be a typographical mistake.
So the revenue and the expenses are actually pretty close.
Yeah, actually, as I'm looking at it, the comma is simply in the wrong place.
Right.
It's $3,165,018.
Fine, so we're not losing a fortune if projected, which is always,
Right.
but, you know, project, that's nice to do. So why are you, just out of a policy question, it seems to me that the major way that the field is looking at psychiatry and substance abuse is that it's an integrated part of health, and that there's no particular logic to separating it out, that in fact substance abuse should be treated like any other illness within the medical community. Psychiatric stuff doesn't need to be in special places 2 miles away from the rest of the population. So I guess I'm a little bit concerned about the whole concept of building a separate psychiatric facility when it seems that the integration of care is where the field and at least, you know, some governmental agencies have espoused. So I guess for both the state and from the hospital, I guess I'd like to know the logic for doing it. And then from the state, I'd like to understand your logic for thinking this is a good idea. So whoever wishes to go first.
Sure. So first, I just want to recognize that we assumed responsibility for this service in Oswego in 1981. It's still located in the same facility, an Oswego County building owned by the county, as it was in 1981.
Okay.
At that time, services were not integrated. When we first made application for the grant funds starting in 2011 and were awarded in 17, we went through a process with the Department of Health that helped us understand how best to manage the location. Our first application was for $34 million, I believe, to relocate from this county location to the hospital's main campus so we could fully integrate that service. At one point during those discussions and applications and rejections of applications, Dan Shepard and I spoke about exactly what it was that we needed to do to be successful and replace this facility at another location without coming onto the main campus. Our main campus is landlocked. It's not an area that's easy to develop without going into the neighborhood, removing properties, and then having to rebuild that entire space. So conversely, we were able to develop a plan at another campus that allowed us to get the facility closer to the hospital, so access between the emergency department and our inpatient facility were improved, but we still are off-site, and that allowed us to save, quite frankly, about $15 million in the cost of this project.
Yeah, and I can vouch for what Mr. Coakley's saying. I was privy to a few of those conversations over the past few years where their intent certainly was to consolidate all services at the main hospital campus. There simply, to the best of my knowledge, wasn't enough state capital dollars to be able to help achieve that. From OMH's perspective, again, going back to proposals that we've brought to the committee for particularly upstate areas, but even on Long Island, and we're seeing applications or at least inquiries from the city now. There, with the diminished resources and particularly staffing availability, there's been a notion of having consolidated behavioral health centers of excellence, is a phrase a few health systems have thrown out. It's actually a notion that is supported by OMH executive leadership, if done right. And by done right, I think it's safe to say that not just keeping the psychiatric inpatient units and beds off campus from the main hospital, but building up around those with a combination of clinic, partial hospitalization, crisis services. In particular, the commissioner is big on pushing crisis residential beds as an option at such centers. She's also encouraged that the CPEPs be located at such centers. So this is actually something that we've had a few. Dr. Martin, I think, as you may know, Mount Sinai is pursuing a very similar proposal.
Oh, my employers do stupid things all the time in my career, as I'm sure most of ours do. That's no concern of mine.
Yep.
Now, let me say, the CPAP or the emergency room?
CPEP.
Or it would be.
And I think, but you're getting to an excellent point, and that's where, from OMH's position, we've had questions on how they would handle the medical triaging and assessments prior to CPEP, or whether that would be done at the CPEP. These are still discussions that are in the planning stages and still taking place. OMH certainly needs to know more about how such consolidations would take place in such centers. But yeah, that's exactly the type of questions we're asking as well.
Okay, so can I ask the applicant, at this point, is your emergency, I assume you're a 939 receiving facility, or am I wrong?
Yes, well, we are in our emergency department. We're receiving these patients. These patients then are transferred, if necessary, to have inpatient service to this location that currently is about 2 miles from us at Bunner Street, and would be about 1 mile from our emergency department following this transition.
Yes.
But are you thinking of moving the psychiatric emergency services to this new spot 1 mile away from the general hospital, or would you still have integrated emergency services and then work up people properly and stabilize and then worry about where you're transferring them to?
We've actually done a lot of work to integrate those services and do that so we can provide the highest level of quality care in the emergency department and then make sure people get to the right place at the right time following that. We've also done a lot of work to integrate that hospitalist service. Dr. Mandanis has supported the development of that hospitalist service available for consultations and rounds at the psychiatric facility to support those psychiatrists with those acute care needs that those patients have in our facility off the main campus at the psychiatric center.
And there are walk-in services available even at the main campus now.
Right.
At the behavioral services campus now.
Yeah. Well, if they walk in, I'm less concerned, frankly.
Right.
It's the ones dragged in by the police, or those that are clearly delirious and are thought to be psychiatric and sent to psych hospitals, which happen every moment of every day.
Dr. Martin, I could,
medical record?
if I could just add too on that last point, Oswego's been doing this now for over 30 years. As you know, we brought the Arnott Health applications, I think it might have been even last cycle, where they're looking to have their inpatient building separate from the building with the ED. And as you know, that was an area that we really worked with them hard on to make sure they had a plan in place on how they were going to properly do that. So again, that's an area that's always a focus for OMH as we evaluate such applications.
No, I understand. Just curious what their plans were. And electronic medical records, I'm guessing you're using, and they will be integrated fully. There will be no problems with communicating between campuses and other outpatient facilities in your system?
Yes. In fact, they're integrated right now, even as we speak, and it's being utilized for both the main campus as well as the behavioral health services.
Okay. What system are you using, if I may ask?
Meditech, we recently upgraded to Expanse, to the latest version. That's being used on both ambulatory as well as inpatient behavioral health services.
Okay, thank you. And which health information exchange are you guys associated with?
With the Syracuse Behavioral Health Service, ConnectCare. No, I'm sorry.
Healthy Connections.
Healthy Connections.
Healthy Connections, okay, thank you. All right. Well, Ralph suggested I would ask enough questions that other people might not have any. He may not have known what he was getting into.
Thank you.
But would still ask any questions that committee members have.
What's your time frame?
We're actually prepared to close on the building now. We have been for some time. So the Oswego County Industrial Development Agency owns the building. So we're prepared to close on the building, do some abatement there just for asbestos on flooring, and then be able to start construction within 6 weeks.
That's good.
What happens to your current location, the building that you're currently in?
Actually, the County of Oswego has already sent designers in to repurpose that facility so they can then use that for record storage, documentation, as well as building some space for some of their judicial members that need additional office space. So they're going to repurpose it within that county facility.
Okay. Any other questions? All right, so we'll, as we usually do, the motion will be in the affirmative. So the vote will be to give a favorable recommendation going forward to the full council. Any further discussion? If not, we shall vote. All those in favor?
Aye.
Okay, so the vote is positive. We will give a positive recommendation later on this afternoon to the full committee. So, gentlemen, thank you very much.
Thank you.
For being here, and your answers were clear and very helpful, so thank you.
Thank you for the questions and the support.
Thank you.
And Keith, your answers were nice also.
As usual.
My beef with the executive is something I can deal with myself.
I was going to say, I am confident that you will have your own conversations.
I'll be happy to express my views. Which will be whatever. I'm in enough trouble. All right, we move on then to Counseling Services of Upstate New York, a clinic treatment program, MHA 2823 in beautiful Erie County.
Yes, sir.
Keith, tell us more.
Certainly. Counseling Services of Upstate New York, CSUNY, a subsidiary of VentureForth, Inc., which is a DOH-approved licensed home care services agency, requests approval to become an Article 31 sponsor for purposes of establishing a clinic treatment program to serve adults with an emphasis on individuals with physical disabilities. The location for the proposed clinic is 937 Broadway in Buffalo. CSUNY is a proprietary organization with John Zwitt as its president and owner. Mr. Zwitt started VentureForth, Inc. in 1997 through the Traumatic Brain Injury Waiver Program, focusing on work with local veterans in need. The applicant's parent company, VFI, has over 20 years of experience providing licensed home care services and Medicaid waiver services such as TBI and nursing home transition and diversion. They have also been one of the largest providers of behavioral health, home and community-based services in the state. The applicant cites an unmet need in the mental health service delivery system for individuals with physical, intellectual, and developmental disabilities, as well as those with neurological impairments and TBI. The applicant states that when contacting local clinics, the one closest to their proposed location was not accepting new clients. To meet the needs of and be accessible to the intended population, the applicant proposes having set walk-in hours and use the mobility allowed by the licensed behavioral health practitioner benefit to provide continuity of care during periods when clients are not able to attend appointments for clinical or medical reasons. OMH is recommending approval.
Okie dokie. Is the applicant around?
Yes.
They are in Rochester.
Yeah, I figured that where you would be. Not that I could necessarily say where Erie County is directly. Okay, so could you, welcome. Oh, you want to introduce yourself, please?
Yes, my name is James Treader. I'm the administrator of VentureForth.
Okay.
My name is Michelle McLean. I'm the controller for VentureForth. I'm Heidi Rodriguez. I'm the clinical supervisor for VentureForth and anticipated clinical director of the new clinic.
Okay.
I'm John Tennant, the owner of VentureForth. Chris Roche, clinical director at VentureForth.
Oh, good. So everyone we need is here. No, good, thank you. That's great. So I guess I'm a little bit, can you explain, I guess, the staffing? Because I'm not, so there's a term, mental health clinician, and can you explain to me just what that means?
Sure, the mental health clinician is going to be a licensed professional who will be providing psychotherapy services. So this may be an LMHC, an LMSW. We differentiated the LCSWR because we were specifically making sure that we had an LCSWR for cases who had Medicare or one of the other plans that would not pay for anybody other than an LMS or LCSWR.
Okay, so these will be non-physician, non-psychologist, so do they have licenses of some sort? I don't even. Social work.
Yes,
They're all
absolutely,
gonna
like
be-
worker or mental health counselor.
Fine, okay, but that's, all right. So well, no, it says that's how I said, but they will be social workers, they just won't be the specifics of the social worker that they are, that you're gonna have. Got it. So you got a psychiatrist 1 day a week, spread out?
Correct, yes.
Nurse practitioner, 0.35, registered nurse, hardly there. Why do you need a 0.1 registered nurse? I guess for dispensing meds or something, or giving meds or something?
The
What's the
injectables.
point?
The injectables, if we had to need down the road to review medical histories of individuals when they come in, when they're first starting with us.
Yeah.
Somewhat of an assistant to the physician.
Okay. And the clinic director, qualifications, experience?
Licensed mental health counselor. I've been with Venture Forth for 8 years, supervising 5 of those years. Prior to that, I have, let's see, going back, maybe 5 years of experience, I can't remember off the top of my head, as a counselor with People Inc. and Spectrum Services.
Okay. Thank you.
You're welcome.
And again, could you explain a little bit better, to me at least, and I'm guessing others, so how are you integrated in, I guess, can you better explain how you're integrated into the care delivery system up there? I presume that these patients, some of them are going to have a bunch of medical problems in addition to just the behavioral issues that you're trying to help them with. So just how integrated is this, and how does that work, or how's it going to work in this new clinic?
Well, right now we are a community-based organization that interacts strongly with our county hospital, BCMC, and we have a good relation there. And we also interact a lot with local physicians, a lot of the federally qualified clinics. We have employees embedded in those locations as well. So with our experience already on the Venture Forth side, we're integrated, we're familiar with our patients being admitted to the hospital, discharged from hospitals, how to assess a patient after they come out of the hospital, and we have those resources. So we have a pretty strong history with integration within community organizations and hospitals and physicians.
Excellent. Thank you. How many of your patients end up getting hospitalized psychiatrically? I assume it's not a huge number, but...
It's not a huge number. I'd say more so through our home and community, or home and community-based services program. It's a handful. We've maybe seen 5 since we've started home and community-based services 2.5 years ago.
All right. Okay. You've managed to avoid suicide, I hope?
Yes.
Knock on wood?
Yes. Specifically, yes, we have helped people.
Okay. All right, well, that's good. Wasn't lucky, but it's good. All right. You'll be providing full medication treatment if required. There's no medications you wouldn't use as modalities. If somebody happened to also have the need for Clozaril, for example, would there be a problem to use it, or any other treatment modality we should be aware of? I doubt it's not common, but.
No, we would handle that if needed.
Okay. So there's no a priori reason not to. I'm not going to ask you about ketamine. Or ECT. Or a bunch of other things you can waste time on, yeah. All right. Ralph.
So can you address the targeted population and the documented need, and are you prepared to just do generic clinic work with people without physical disabilities? Like how do you know you'll have these 150 people who will come to these services?
Yes, absolutely. Before we chose our location, we did a lot of research throughout Western New York of which zip codes specifically still had a high risk for mental health needs and a lot of unmet needs. And we found that the east side of Buffalo, 14212, 14211, still had a very high risk and a lot of mental health needs. So that's why we chose the area we did. We, at that moment, were not looking specifically for whether the people with those needs had a disability or not. This was just people with mental health needs. We chose to state that we will specialize in working with people with disabilities because of the history of Venture Forth. Chris and I, as clinical providers, clinical directors, have many years of experience working with people with disabilities through People Inc. So that is an area we have found in many ways to be still a need. So that is why we are specifically working with those individuals, but we absolutely will work with anybody with a qualifying mental health diagnosis.
Thank you. And your plans for transportation, I assume this is a population that requires transportation services?
They may. Most of the population should be eligible for Medicaid cab, and we are right on a bus route. There's a bus stop very, very close to the anticipated location.
Okay, thank you.
You're welcome.
Okay. Anything else? Anyone else? All right. So, once again, we'll form the motion as a positive. The motion will be to recommend approval to the full council later in the afternoon for this project. Any further discussion? Seeing none, let's vote. All those in favor?
Aye.
All right. So it will go forward with a positive recommendation. I suspect they'll listen to us, so good luck.
Thank you very much.
Thank you.
With your project. Thank you. Good luck.
Thank you.
All right. So the next project is a bear, only because there are more moving parts in this than probably any other project that we've seen in a while. All right, so let's start off. Is the applicant here in the room? Is there an applicant anywhere?
I believe they're right next to you. They don't realize who you're talking about yet, Dr. Martin.
Charles Evans?
Yeah.
Yeah, that's what I thought, okay. Oh yes, no, you missed your cue, okay. All right, so the applicant, well, we're going to do introductions in a minute. Applicant's in this room. So this is a kind of joint because it involves both OMH and OASIS.
Yep.
I think, Keith, you got elected to try to tell us what's going on.
Yes, I'm always very lucky.
And Oasis gets to sort of piggyback on your explanation because of various different programs are moving.
Yes, sir.
Both agencies are involved. So Keith, if you could go through it, the applicant will pay very close attention to all the mistakes you're going to make or not. And I'm very optimistic. You almost got me understanding it the last time. So let's try again.
And I just want to add that for the committee realizes that you'll need to vote twice, once on each application.
Right.
So,
Absolutely.
just wanted to
It'll be
highlight that.
two separate motions and the like. Absolutely.
Yes, sir. So the OASIS application is number 2018.135. The OMH application is MHE 2825, Charles Evans Center, Inc. They are a DOH licensed Article 28 and OPWDD licensed Article 16 provider, and currently requesting approval to become both an Article 31 and Article 32 sponsor. On the Article 31 OMH side, it's for purposes of assuming the programs currently operated by the Angelo J. Melillo Center for Mental Health. This includes a clinic treatment program and an ACT program, both located in Glen Cove, and 3 community residences also in Nassau County. The committee may recall that Charles Evans Center, Inc. was previously an Article 31 sponsor and operator of a clinic treatment program in Bethpage, which opened in October 2015 to serve adults, adolescents, and children. In August 2017, Charles Evans Center voluntarily surrendered its license subsequent to a recommendation by OMH due to an inability to become operational and meet basic standards of care for clinic services. The agency has since undergone a complete change in leadership, recruiting individuals with significant mental health experience throughout Nassau County. Conversely, the Angelo J. Melillo Center has experienced significant problems operating its programs, as evidenced by the results of OMH's agency-wide recertification visit in April 2016 and fiscal audit conducted in 2018. Although the agency submitted a satisfactory performance improvement plan in response to the visit and corrective action plan relative to the audit, it has continued to evidence significant fiscal difficulties. Charles Evans Center indicates that it can adequately assume and manage the Malolo programs fiscally, correcting the deficiencies that existed previously. They have also indicated that clinical staffing at the programs will remain the same, being brought in under Charles Evans Health Center, providing the necessary operational experience to provide continuity of these services. LMH is recommending approval.
Okay, let me do something a little bit unusual. From the Oasis point of view, is there anything pertinent that you need to add now so we understand the global nature of this?
I think, Linda, let me just try to jump in a little bit for you. I think the piece we would want to add that the Malolo Center operates a one Oasis outpatient clinic. They are currently in good standing, and that would be the one program that would be merged into the Charles Evans Center. We did get a positive reaction from both the LGU and the Oasis regional office, and I think that that's all we would want to add.
Okay, so you were one clinic among the many things being moved over, and from your point of view, that clinic was working well to begin with, everyone's okay with it being transferred, and that's pretty much your guys' position?
Correct.
Okay. Excellent. So the applicants in the room, can you guys introduce yourselves? Whoever?
I'm Jim Nolan, the Executive Director of the Charles Evans Center.
Okay.
Bob Goldsmith, board member. Peter Millard, Nixon Peabody, council, 2%.
Okay, thank you. All right. Can you, we'll start with questions. Can you just give us a little bit of a narrative of, you came here, you asked us for permission, we said yes, and then after a couple of years, we gave up or it just didn't work, or you gave it back, now you're going to try again. So can you give us a bit of an explanation, a bit of a better, fill out Keith's story for us?
Well, just in terms of the presentation from Keith, it was an excellent summary, and our partnership with OMH and Oasis has really been tremendously helpful to us. And along those lines, OMH, this is prior to my time at the Charles Evans Center. I've been there for about a year and a half now. Okay. But I know leading up to my arrival at the Charles Evans Center, OMH was very helpful to the Charles Evans Center in helping them to structure an approach that will enable them to continue to deliver behavioral health services at the center. They provide about 12,000 behavioral health visits a year. So again, with the support from OMH and DOH, we received the 3AI district waiver, enabling us to deliver behavioral health services to that level. So we bring into this current situation an extensive experience as a behavioral health service provider. We have my second in command in terms of behavioral health care, as Keith mentioned, is also a very experienced mental health clinician and administrator. We have 2 psychiatrists on staff, a nurse practitioner, 2 psychologists, both social workers, social work interns. So I think we bring a rich background and administrative know-how into this situation. So the opportunity to form this partnership with Malolo kind of fell into our lap based on the role I had in the past as acting commissioner of the Department of Human Services of Nassau County. I am sensitive to that the freestanding Article 31s are in. Led to a conversation between us and Malolo, and for the reasons that Keith mentioned, the struggles that they're having. So this kind of partnership will financially address that. And from a patient care perspective, this is a real boon for them. We're going to be able to co-locate, as you were kind of alluding to before, Dr. Martin. The end game is to be able to co-locate a range of behavioral health, physical health care, and dental services all at one site. So of course the best thing we can do for our patient population is not only provide high quality care, but make it as accessible as possible. So the Glencoe community and the surrounding areas certainly would benefit from this service that we do.
So during that period of time, so it sounds like even though you guys came in and were planning on expanding under a new license and that didn't work out, you were still busily providing care under the workaround through district. You're saying you've developed a fair amount of experience operationally, internally, even without this. Got it. There's a line here, and this may be for Keith, maybe, I don't know. In the introduction, it says, the Meal Center also operates several unlicensed supported housing programs, the leases of which will be assumed, et cetera, et cetera. So unlicensed implies to me that that's not good. Am I wrong?
No. Yes, I'm sure Ralph will educate you on our housing.
Yeah, no, I'm just saying, you just left it hanging. So could we explain why this is a good thing and we should not be perturbed, or whether they should get them licensed or whatever?
Yeah, so I guess I should clarify for the rest of the members that
Even everyone else.
yeah, all unlicensed means is it's, our housing is either licensed or funded but not licensed. So it is still funded and supported by OMH. It's just not licensed housing. It's a different category of housing. Fully supportive, fully good.
You probably should have left the word unlicensed out. These are programs that are subsidized through OMH, also Oasis,
Right.
supportive housing.
Are they regulated? They get money, but they get regulated, they get inspected, they see
Yes.
what's going on? Yes. Thank you.
Yes.
So what does the license get you?
More money? So one distinction is the license tends to be transitional in nature, and the unlicensed tends to be permanent supportive housing. It's a place where people live, and they can live there for long periods of time, and receive supports.
Right. Okay. So you have like permanent housing.
And I'm sure there's a tremendously brilliant reason that got us here.
Yeah, you're an FQHC. Correct. Right. So you provided mental health services before you had a license, right? Did you do any?
Yes,
mental
that's
health?
what I was
Right, with the
saying
district.
before, that we are currently under FQHC status, also provide behavioral health care.
Right, so now you're looking to have an OH license, again, it's a forensic one, and you have different leadership, different people with different expertise to be able to do that.
That's right.
You're moving then the Oasis is an 822, it's going to be integrated with a mental health program
That's right.
at your location.
At the Glen Cove site, at the current Willow site.
Okay, so how many locations do you have for each line services?
So we currently have, Charles Evans Center currently has 2 locations, one in Bethpage and Hauppauge. Okay, the Willow site is in Glen Cove.
But the plan will be to integrate both
Right, at
Oasis.
the Willow site has 31 and Article 31 and a 32 currently,
Right.
and at a later point we'll be incorporating the Articles.
Okay.
You're all hooked up electronically and everything, or you're going to be doing that, or you already?
Yes, they have the software and the hardware that enables us to do a fairly seamless.
Are you guys hooked up with your Rio for your mental health also, do you know?
Yes.
Okay. Just curious. Ralph, did you have a question?
Can you talk about the staffing? I know the application says that there are no changes, no proposed changes to the staffing. I'm not sure if that's the staffing pattern or the actual employees. Like, how are you going to deal with the actual employees at Melillo?
We expect to maintain a very large percentage of the current employees. So it will be seamless from the patient's point of view in terms of the change in ownership, change of sponsor. So the direct care staff, we expect that the vast majority of them will be
And they've been told that?
patients.
No, the staff.
Tomorrow,
The staff.
patients.
The staff. I mean, oftentimes what happens in this, people start jumping ship. They get nervous, and then you lose the continuity of care.
The staff are aware.
Okay. All right, so you, as an FQHC, you're already beholden to HRSA, right? So you follow that structure.
That's correct.
So your board will then be the board that will assume responsibility.
It's a very actively involved board, as you may know, under HRSA requirements. We meet monthly. Finance subcommittee meets monthly. So it's a very tightly controlled and very closely supervised operation.
And you currently meet their standards of the compensation.
We do. We had a audit recently that was conducted. We're a subrecipient under Hudson River Healthcare. They and us were recently audited by HRSA, and we received a score of 100%.
Thank you.
And here I thought the Hudson River wasn't near Long Island. It's just, it just becomes impossible to keep track of.
We get to Wars Island.
I know, Hell's Gate, we'll have a conversation in a minute. But this is, you just can't keep track of it. All right, so Keith, just one question.
Yes, sir.
There's a condition out of the Long Island field office about the audit, not apparently of of Charles Evans, but back to the Melio Center. Will this in any way hold this up or screw this up, or is this something that will be subsumed by Charles Evans, I guess, is their responsibility going forward, or what does this mean?
I think it's safe to say that this condition is put in there to protect all parties. That OMH is not expecting to find anything based on what we've received writtenly and what's been conveyed to us verbally. It's a requisite check to go out and do a follow-up visit. And Charles Evans is well aware of what the fiscal difficulties and the findings of the audit were. So this is more just, to protect everybody. Charles Evans isn't expecting the merger to go final until June 1. So our audit team had agreed to go out prior to that, just to make sure nothing averse is found that would need to be alerted to the new operator.
Okay. But as part of due diligence, I assume you've seen everything you wanted to see up until now. Yeah. Okay. Yes, it is, as you said, more of a CYA, so the last check than anything significant. Gotcha. Okay. Anyone else got questions? Or any more questions?
Community reaction, any?
Community reaction, they're asking if there was any. Is the community aware of it? Is this like a hostile takeover?
The current executive director of the Mello Center has been in touch with the local mayor. He's aware. Everyone is supportive.
Has the press commented on it at all, Dino?
It's not really that.
It's not that interesting. Yeah, okay. No, which is good. We're happy with that.
They've been pretty, I thought I read that there were pretty extensive meetings with the county, the community, and like,
Extensive meetings
with the community, the county, it's pretty much on board.
Well, the local community is going to be very pleased by this.
Right.
I'm not sure what meetings are you referring to, but it should be very well received.
Okay.
Yeah. Okay, any other questions? Seeing none, as usual, we'll do this in two motions as mentioned, and then we'll shift, and then we'll continue going with Oasis. So for now, the last OM8 project, MHE 2825, specifically referring to Charles, Evan, and non-Oasis services. Motion is for a positive recommendation later this afternoon. All in favor?
Aye.
Okay, anyone opposed? All right, so that will go favorably. And now a second motion from the Oasis calendar, 2018.135, and this would be a motion to approve the merger and acquisition and making Charles Evan a new Oasis provider. Any discussion on that in particular that anyone wants to have? All right, seeing none, the motion is made in the positive. All those in favor?
Aye.
Aye.
Anyone opposed? All right, so that'll go with a favorable recommendation to the council. Again, with the expectation they'll agree with us. Good luck.
Good luck, thank you.
Thank you.
This wasn't the most complicated we've done.
All right, so we have transitioned seamlessly to the Oasis agenda. And we start off with my favorite thing, which is crossing out the first. It has been pulled from the agenda. Well done.
Yes.
Beacon is gone. However, the Addiction Care Center of Albany, even if it's not in Albany, it's in counties north of Albany. Gail, tell us all about this capital project, please.
Good morning. This is a capital project application from Addictions Care Center of Albany, Inc. to acquire and renovate a facility located at 79 Glenwood Avenue in Queensbury, where they will establish a new 15-bed Part 820 residential program for women. The total approved cost of this project is $3,047,000. The existing 8,700 square foot building is in very good condition, but currently used as professional office space, so will need to be renovated to meet the needs of a residential program, and that includes construction of resident bedrooms, bathrooms, kitchen, laundry rooms, and various program areas, as well as modifications to the mechanical, electrical, and plumbing systems. ACCA was awarded under a Warren County request for proposals to establish residential addiction treatment and substance abuse recovery services using operational state aid that had previously been allocated to 820 River Street for a women's residential program that has recently closed. ACCA has been an OASIS certified provider since at least 1995, currently operates 4 certified programs, all are operating in good standing. The 820 River Street program community residential service that closed in May of 2018 was the only women's residential program in the region, so this proposed new program will preserve those much-needed services. The applicant proposes to provide all 3 elements of Part 820, which means residents can be admitted into any of the 3 elements and then progress to other elements as appropriate while remaining within that same facility. All programmatic aspects of the 820 services will need to be reviewed and accepted by OASIS prior to final approval of this application once construction is complete. ACCA does currently have in their most recent OASIS fiscal viability review scores that would qualify them for only a 6-month renewal. However, according to our fiscal audit and review unit, they have submitted an acceptable financial recovery plan. They did submit a preliminary budget for this program, which includes OASIS state aid and is not currently showing as balanced. However, once more the program is more finalized, balanced, budget will need to be submitted and reviewed and approved by our regional office and state aid verified. Warren County Community Services submitted a recommendation to approve, signed by Director Rob York. Albany County Department of Mental Health, which is the LGU for the applicant's administrative location, also submitted a recommendation to approve. OASIS Hudson Regional Office recommended approval as well. A state environmental quality review found that the proposed action does not require further environmental review, and a physical plant inspection will be completed when the facility is finished. The construction is completed. OASIS recommendation is to approve this request for the capital project with 2 contingencies: inspection and approval of the final completed facility, and approval of the programmatic elements for the Part 820 services, including program description, policies and procedures, staffing, and budget. That's it.
All right. Thank you. Is the applicant around?
I believe, yes. We have the executive director of ACCA.
Yep.
Okay, welcome. All right, committee members, any questions?
No.
Concerns or comments?
Nope.
Well, the one comment is I'm very happy you're finally opening up there. We've been looking for a woman's place up there for a long time, so hopefully it'll go through. Congratulations on that.
All right, I'll take that as a positive comment. Ralph.
Question on the zoning, do we have zoning approvals?
Yes, Keith Stack, yes, we do. We were required to submit the proposal for site plan review to the Town of Queensbury Planning Board and received approval January 15th of this year.
Congratulations.
Okay. Any other questions? Okay. Then it looks like we're ready to vote. As usual, we'll do it in the positive. So this will be a motion to approve certification application 2018068 with a positive recommendation to the full council later this afternoon. Any further discussion? Seeing and hearing nothing, we will vote. All those in favor, please indicate it.
Aye.
Aye.
Thank you. All right, so that'll go forward with a positive recommendation and good luck. And as was mentioned, it is a needed service, and it's nice to see it being provided. Great. Next up, the Lafayette Medical Approach LLC, a change in ownership. It looked fairly straightforward, but if you can go through it, please.
Absolutely.
Linda?
Good morning.
Morning.
Good morning.
Lafayette Medical Approach LLC submitted certification application 2018-130 requesting approval for a change in ownership of their Part 822 opioid treatment program located at 233-235 Lafayette Street in New York. The change in ownership is a result of the passing of Dr. Massimo DiGiardi, who had an 80% membership interest in Lafayette Medical Approach. In his last will and testament, Dr. DiGiardi left 40% of his 80% membership to each of his two sons, Robert and Anthony. Prior to Dr. DiGiardi's passing, Robert and Anthony each had 10% membership in Lafayette Medical Approach. With this change in ownership, Robert and Anthony will both be equal members of the LLC, each having 50% membership interest. Lafayette Medical Approach is an existing OASIS entity certified to provide Part 822 opioid treatment services. They're accredited by CARF and certified by SAMHSA. They've been serving downtown New York City and Brooklyn communities for over 40 years. They're also licensed by the New York State Department of Health and are in good standing with them as well. Based on the most recent recertification review of this program in January of 2017, the provider received scores indicating substantial compliance and received a 3-year operating certificate. Lafayette Medical Approach has an acceptable fiscal viability standing, and they do not receive any OASIS funding. Lafayette will also continue to utilize the policies and procedures that have been previously reviewed and accepted by OASIS, and there are no changes to the current staffing pattern or budget. Robert DiGiardi has served as the executive director of Lafayette Medical Approach from 2014 to present, and his role involved all clinic-related issues, both managerial and in a hands-on capacity. Anthony DiGiardi has served as an executive officer and systems administrator of Lafayette Medical Approach from 2004 to present, and in these roles he is involved in both the daily functions and operations of the clinic, as well as updating and maintaining the clinic's computer systems. Both the New York City Department of Health and Mental Hygiene and the New York City Regional Office recommend approval of the application. The character and competence applicant review was submitted with the application and reviewed, and there are no areas of concern. And OASIS recommendation is to approve the request of Lafayette Medical Approach for a change in ownership of their Part 822 opioid treatment program.
Thank you.
You're welcome.
Is the applicant here? You're the son? Yes. First, my condolences on your passing. All right. Fairly straightforward. Both of you guys have been involved in the operations, it seems, at various different levels forever, or close to that. Okay.
Well, one of you
grew up there, right? It's our home.
Yes. Right. So you can explain, so what were you doing exactly, just for the record?
So I'm the executive director, pretty much involved in, we wear a lot of hats. We share hats sometimes too. So, basically I'm the executive director involved in, pretty much any day-to-day operations. Also including, CARF visits, audits. I mean, you name it. Whatever happens, it's my desk, and then we divvy out the responsibilities.
So it appears nothing's really changed, except unfortunately that's gone. And he taught you guys well.
All right.
All right. That's important.
All right, so it sounds like everyone thinks the organization has done a good job. No one is raising any flags. You guys have drank the Kool-Aid and willing to continue, which is very nice, thank you. And I see you're adding Butte, which is a nice, moving into the later thing, which is great also, absolutely. All right, any other questions for anybody?
No.
Please, Tino.
What are your referral sources?
Referral sources, a lot of word of mouth. We've got a network of clinics that we met with our program director, keeps in touch with their program directors, and a lot of referrals happen that way. Pretty much that's
I have a question for Gail Keith. I don't know who's the right person. This is not really related necessarily to this program. I just want to know how do you calculate this viability rating of 2.62? I don't know what's the formula to get.
Dr. or Tino, it's a asset to liability ratio that's done by our fiscal people, and they score it based on how high of an asset ratio to liability ratio is, and the higher you are, the better you are.
Oh,
Wow, that's all, yeah. The higher you are, the better you are. That's good, in a way.
It's bringing it out to the
Just saying.
but it's also it's bringing it out to the second decimal place, and I'm very impressed with the precision.
Yeah.
So what's the acceptable bar? Just a curiosity.
We like a one-to-one. We like a one-to-one assets to liabilities, and so these are
Very good.
much higher, as you
Right.
can see.
You know, we got
Almost stone.
Okay,
we're good.
great.
Almost,
Oh,
yeah.
so you're down further south than I thought. So you're what, at Lafayette and
Doing geography.
Yeah, no, well, Passover, I had no idea it was there. Okay, yeah, we usually get a map. We get maps for certain things.
Yeah,
We didn't get a street map.
Because I work for the state, I know that I have a small conversion of upstate New York and you.
Well, that's for sure. No, I do, but we're a statewide, we're a statewide, I know exactly where it is. We're a statewide, committee. I had no idea where the previous place was because it was between Gloversdale and Vermont. Forgive the map. All right, enough idle chit chat. Let us move forward. Does anyone have a substantive question or comment to make at this time? Hearing none, we shall vote. It'll again be a positive, motion will be in the positive to recommend approval of the change of ownership for the Lafayette Medical Approach, 2018-130. Any further comments, discussions? Seeing none, we'll vote. All those in favor?
Aye.
Aye.
All right, so we will go forth with a positive recommendation to the council and fully expect it to continue to let you do what apparently is your calling, and we're very happy for it. So good luck. We move on now to, Odyssey House.
All right.
2019.006, a capital project. The applicant I know is in the room. Would you like to introduce yourself?
Come on, guys. I'm the Vice President, Director of Residential Services.
Did you guys hear that he was wandering to a better seat?
Yes.
You heard, okay. So, Linda, are you doing this one also?
Yes, I am.
All right, so take it away.
All righty. Odyssey House, Inc. has submitted this capital project application 2019006, requesting approval for the construction of a new 19,827 square foot, three-story facility adjacent to building number 13 at Hellgate Circle on Wards Island in Manhattan. The project is in the design phase and has a projected cost of $16,061,000. The building is being referred to as an annex to the current building, as it will be connected to building number 13 that currently houses Odyssey House's 97-bed, Part 819 George Rosenfeld Center for Recovery and their 74-bed, Part 819 Women and Children's Program. It will be connected via a ground floor breezeway, which will allow the flow of staff and materials and prepared meals from the central kitchen into the existing building. The building is being constructed to accommodate the relocation of Odyssey House's 60-bed Young Adult Male Leadership Center, which is currently located at 309-311 East 6th Street, New York. The Leadership Center serves young adult males between the ages of 18 and 25 in a residential setting. These clients are primarily referred through the criminal justice system. The 309-311 East 6th Street building is currently operating as a grandfathered program, as it's lacking Americans with Disabilities Act accessibility with cramped space. Efforts to modernize and expand this space have been complicated by the building's age and the fact that it's designated as a landmarked facility, which would significantly add to the cost of the renovations. Odyssey House has been searching for a suitable replacement facility for the Leadership Center for several years to no avail. The stigma of a male adolescent program with criminal justice clients adds to the difficulty of citing such a program. The Wards Island site presents a unique opportunity to construct an annex facility to accommodate this 60-bed program. It will be constructed on land owned by the New York City Department of Parks and Recreation, but leased to the Office of Mental Health under the terms of a lease that covers the Manhattan Psychiatric Center. The Office of Mental Health, in turn, leases the land to Odyssey House via a DASNY-held 40-year long-term sublease. The sublease includes provisions for Odyssey House to construct and operate the proposed new 60-bed residential facility. The new building will also give the programs the space they require to convert to a Part 820 residential rehabilitation and reintegration program. The Odyssey House was founded in 1967 as a comprehensive social services agency based in New York City. Their programs help individuals and families deal with substance use disorders, mental illness, homelessness, and medical problems. They've been an OASIS certified provider since 1995, and at least 1995, and have currently certified Part 819 programs and one certified Part 822 outpatient program. The Odyssey House's financial statements have been reviewed and they have been found to be fiscally viable. The 5 current Part 819 programs are operating in substantial compliance with 3-year operating certificates, and their Part 822 outpatient program is operating in partial compliance with a 2-year operating certificate. Odyssey House will submit a Part 820 conversion application to provide rehabilitation and reintegration services as the project nears completion. The New York City Department of Health and Mental Hygiene and the OASIS New York City Regional Office both recommend approval of the application, and OASIS's recommendation is to approve the application contingent upon the completion of the construction and the inspection of the space by OASIS's Facilities Evaluation and Inspection Unit and the submission and approval of a Part 820 conversion application.
That's it?
That's it.
Thank you very much. That was wonderful. There's been a conversation earlier, so allow me to annoy you with a little bit of history about the term Hellgate. Hellgate was actually first appeared in the Dutch map back in well before the 17th century, describing the East River because it could mean either a bright strait or a clear opening. And then when and that was back in 1614. And then when the British came, if anyone knows the geography of New York, the Long Island Sound and the East River come together there. And there are something like, 100 or so shipwrecks just in the 19th century. Yeah, it's a really nasty place to put your boat. So Hell's Gate is actually a long and perfectly wonderful term. I mean, the fact that we had to move from the island of Manhattan to here while trying to integrate people into the community, I think speaks loudly about New York and like it not favorably. Having said that, though, yeah, that has nothing to do with your agency. Okay, any questions?
I have a question. Is there an Olmsted issue here of moving, I assume everyone in the place has a mental illness, and we're moving them from the community to part of the island, part of the city that is very institutionalized. I understand that it'll be a newer facility, but has anyone looked at this from an Olmsted perspective?
I don't know what that. I'm not sure what that refers to, but this is an OASIS project, not an OMH project. So I don't know.
Okay, yeah, well, it's similar. All the people will have substance abuse disabilities.
Okay.
And currently, I know the state has been moving away from that for many years and not putting all people together in one building. And the issue has been brought up many times about Homestead.
I think the sponsor would answer the question. I run 820s, and they're really rehabilitation, integration, and one model is stabilization. So it's a brand new model that's been sponsored by OASIS. It's kind of a way of sort of modifying the physical therapy community model in the substance use field. So it's been broken into different stages: stabilization, rehabilitation, integration, and integration, which is the last piece where you put people in the they're stable. so I'm kind of answering the question for you, but, you know.
I mean, I don't know that it's an offset issue. I mean, I know that you're talking about moving into mixed-use housing and things like that. I mean, this is a treatment program still. I mean, ideally, we would have preferred to operate in our current location in the community. It just doesn't seem feasible. We've spent 5 years looking for an alternate site. We have site control, so this is something that is important to us. And we've been operating a program out there since 1973. So, you know, I think we have a track record of being out there and having our clients be able to still be integrated and return to the community.
So moving aside the Olmsted issue, this is one of the integration programs?
This is the rehabilitation and reintegration.
The 820 model is a new model.
So I'm a little troubled that we're moving them from an integrated community to an island where there's mostly institutions.
So I think the thing about Odyssey House, though, is that we do have other sites. So anytime that we've had a situation where somebody needed to be more integrated at that point in the care, most individuals we project will be in the rehabilitation stage. However, we're going to apply to have both opportunities so that we can continue to treat someone that moves to the reintegration. But we have a community residence in the Bronx. We have some other community settings that an individual will be able to transfer to if they needed to for work or.
So there's a choice.
I feel a little uncomfortable, sort of advocating for this, but the process is that there's a length of stay in that program, and people would go through phases, because the next phase would be an integration phase within the community where you could be moved to a community residence or another site. And I know the agency well enough to know they have multiple sites.
I mean, I'm thinking from a family perspective. I'd rather have my family member on East 6th Street than on Woods Island.
I mean, there is precedence for having programs out on these islands over things. I think they really originated from a criminal justice alternatives for incarceration kind of model. Daytop, for instance, with which we acquired, also did the same thing. But you're right. I mean, it's kind of an arduous kind of location to get people to. How do you handle families, family visits and the like?
We have a shuttle that will run to 125th Street. I mean, so if people need, we do it for staff, we do it for clients, we will offer it to families too if need be. I mean, we have a grant right now that has a family outreach worker with a van attached to it, and one of the goals for that was to bring families out to the interactive services.
How far are you away from the shelters located?
There's a shelter relatively close, and then there's another shelter a little bit further. There are 2 shelters out there in the psychiatric center. The island is much different than it was 15 years ago. I mean,
I haven't been there in 25 years.
It's filled with ball fields, and you can sit in one of our lounges and watch a soccer game every day.
I was very impressed by, if I may, because we do a lot with Odyssey at Elevate, and we went to Woods Island to visit it, and it's nothing, and I haven't been there in probably longer than that. That was kind of impressive. It doesn't look like the Woods Island of yesterday. It looks like a new Woods Island that people wouldn't even notice it that way unless you told them.
Parks and Recreation. Parks and Recreation has all kinds of like sports activities out there.
Yeah.
Okay.
And you have all kinds of concerts, all kinds of.
Yeah.
And there's public transportation that's readily available. The bus stop.
Don't go through Hell Gable.
You don't have to go through Hell Gable.
And you're not named the program, though.
No, we didn't take that address. Our old building used to be just building 13, and then the post office gave us that.
We'll call it What the Hell Brigade.
All right.
All right.
So you satisfied that, or?
Yeah,
okay. But you might want to just give a heads up to council, to legal, that it may come up as a question at the full council, and they should just be prepared to give a response. I don't know if it will, but they may want to give them a heads up, please.
Will do.
All right. So we discussed the geography, the history. I think everyone would prefer that you didn't have to go to Woods Island because you couldn't find another spot. But Oasis, do you have any way of just nodding one way or the other about the history of them trying to find a spot other than on the island?
Jeff?
Yeah, they've been consistently trying to find a suitable location. To be honest with you, if their existing site was amenable to ungrandfathering the program, successfully renovating the building, we looked strong and hard at that, and really, this is really their best option. at this
Yep,
point.
no, I get it.
And also, you talked about integrated care. We have actors located at the current building.
Right.
This will bring those individuals much closer to, accessible.
The current building on the island.
Yeah, so these individuals will be able to access medical care, psychiatric care, dental care much more easily than from 6 Street.
And ball field, apparently ball fields.
Well, I'll tell you, the young men like to go out to the park,
Right.
so.
Unfortunately, you're still near the water treatment plant that still stinks.
Yeah.
Sure. Yeah, but that's, I just drive over to Tri-Drive every day. There are just times when you know they're violating more rules than you can count. Okay, cool. Anyone else have any comments, relevant or not?
No.
If not, we shall vote. All those in favor of allowing this Odyssey House to move to Hellgate Circle on Ward's Island, please vote.
Aye.
Hell yeah.
All right, so we enthusiastically. Celebrate. Yeah. All right, congratulations. Good luck.
Thank you. I'll be in touch.
Yes.
All right, and I think next, and this may be the final thing on our agenda, Michelle, I guess, is going to tell us all about 2018.136, access supports for living, that would like to become a new OASIS provider.
That's right. Good morning, everybody. Just to let you know, we do have 3 representatives from Access here. We have Allison Horian. I'm sorry, if you could just say your names.
Ron Calavita, John Bennett.
And if you'd like to join us at the table, that would be great.
Can you indicate what you do for the organization?
I'm Director of Strategy and Staff.
Ron Calavita, the CEO.
John Bennett, I'm the Director of Behavioral Health.
Thank you.
Access Supports for Living is requesting OASIS approval to become a new provider of Part 822 outpatient chemical dependence treatment services at 16-24 Union Street in Middletown, with an additional location at 2123 Grand Street in Newburgh. Treatment will be available to individuals who have co-occurring disorders and complex needs, as well as any other person in need would have the availability for treatment. The applicant was awarded a SAMHSA grant to implement a certified community behavioral health center, which requires integrated substance use disorder, mental health, and primary care services. The applicant is proposing to provide quick access to treatment for opioid abusers through their OASIS clinic that will be co-located with their Article 31 Community Counseling Center in Middletown. The additional location site will be located in their Newburgh Community Counseling Center. The plan for this program coincides with Orange County's Department of Mental Health's plan for opioid prevention, intervention, and treatment. Treatment will allow for second-day continuation of buprenorphine for those who have come through the emergency department, as well as others who are seeking quick availability to medically assisted treatment. Access plans to serve 88 individuals at each location annually, totaling a little more than 13,000 units of service. Hours of operation will be Monday through Friday from 11 a.m. to 7 p.m., and Saturday and Sunday will be 9 a.m. to 5 p.m. at both locations. They will use person-centered, evidence-based practices and include family and social networks, as well as community-centered service providers. They'll provide individual, group, family counseling, stress management, relapse prevention, aftercare counseling, and chemical dependence education groups. Access serves approximately 4,000 people annually in their Article 31 community counseling centers, many of which have co-occurring substance use disorders. There are 9 other certified outpatient clinics and additional locations throughout Orange County. However, this particular service will provide chemical dependence services for those individuals with co-occurring disorders, as well as treatment and medication-assisted treatment to anyone else in need. The Certification Bureau received the local governmental unit review on April 2nd of this year, which was approved by Darcy Miller, the commissioner. And we also received the Hudson Regional Office recommendation to approve also in April of this year. Access has had frequent and regular communication with several members of the community regarding this proposed service. Access is a not-for-profit corporation established in 1963 to support individuals, families, and communities with disabilities and mental illness. They're licensed by OCFS, OMH, OPWDD, and they are CARF accredited. The bylaws were reviewed by OASIS Counsel's Office and determined to be acceptable.
The applicant submitted a copy of the proposed revised certificate of amendment of the restated certificate of incorporation that does include our required operating language. The board of directors, consisting of 22 individuals, with one having chemical dependency experience. The medical director is a triple board certified in psychiatry, addiction medicine, and addiction psychiatry, and he is qualified to prescribe Suboxone. The proposed staffing plan meets the requirements of OASIS. Policies and procedures were reviewed and accepted by the Certification Bureau. We did reach out to OMH, OPWDD, and OCF regarding the compliance standing with those licensing agencies. We did hear back from OMH, who reported that they're in good standing. A fiscal viability review was conducted by the OASIS Fiscal Audit and Review Unit in February of this year and determined that their current and overall financial position is viable. The proposed operating budget for this service anticipates $778,744 in revenue and the same amount in expenses, which results in a balanced budget. The recommendation is to approve this application with 3 contingencies. One would be a copy of the filing receipt from the New York State Department of State, inspection of the facility, and acceptance letters for all required staff positions.
Okay. Acceptance letters make sense, though I just had an employee who didn't show, a new hire didn't show up on Monday, so acceptance letters are lovely, but a breathing individual is even better. But, okay, hopefully that just happens to me and not you guys.
They call that ghost.
Yeah, it's just, I know.
The higher it gets, better you are.
Yeah. Actually, we called 911 to disappear. She used to like to sometimes a transfer. Those were she went. So, neither here nor there. All right. So, great. Any questions from anybody for the applicant?
I just have one question of
Please.
curiosity. What is second day buprenorphine?
Yeah.
John?
Yeah, that would be access to buprenorphine after it's been prescribed in, for example, an emergency department. Yeah. And then we, the following day, would be able to continue the prescription.
Yep.
So our model being,
those who send them out and hope they find something.
so our model being the 7-day-a-week model allows that to be initiated over the weekend, which is one of the gaps in service in the community.
Yeah.
Right.
Yeah, no, it's been entertaining to watch ER sort of pushing it without knowing what they're going to do with them now that they gave them one dose. So.
And Middletown's ahead of the game.
So yeah, no, congratulations. This is actually, this sounds perfect. So. Any other comments or questions or concerns? Anything else? No one about money? We got lots of maps here, many dots. And then, they send it, I think, every program in the lower part of New York. It looks very impressive. If you were running all of them, you're one big agency, was my first thought, but then figured it out. Okay, any other thoughts? If not, we will, as usual, the motion will be as a positive to recommend approval later this afternoon. Any further discussion? Don't see much. Let's vote. All in favor?
Aye.
Anyone opposed? Is there any other business that either agency has to bring to our attention today?
No.
If
Keith, you
not-
have any other business?
Nope.
Nope, we're good, Dr. Martin.
All right, so we will now adjourn, and all of those who are watching for the New York Times and the Washington Post to read the report for us.
Read your tweets, would
You
you?
can keep up to date before we reconvene in a half hour, I guess.
Thank you.
Thank you.
Thank you. Yes, please.
My leader.
You want to go downstairs?
It's nice to see everybody together again. The first thing we always do is introduce ourselves, so why don't we start in Albany?
Hi, Kate Breslin, Schuyler Center for Analysis and Advocacy.
Hi, Stephanie Campbell, Oasis.
Rob Kent, Oasis.
Bill Gutman, Northern Rivers.
Jim Scordo, Cradle Community Center.
Lisa Rademacher, OMH.
Tracy Collins, Oasis.
Jennifer Farrell, Oasis.
Allison Horan, Access Supports for Living.
Ron Colavito, Access Supports for Living.
Janet Pulaski, Oasis.
Dina Holmes, Oasis.
Gail Keeler, Oasis.
Linda Heffron, Oasis.
Keith McCarthy, OMH.
That's it in Albany.
Okay, thank you. And now Rochester, please.
Maura Kelly, Mental Health Peer Connection.
Stephanie Orlando, Western New York Independent Living. Council member.
Okay, and here in New York, I'm Paul Samuels, the chair.
Ann Sullivan, OMH.
Ralph Bassano, Concern for Independent Living.
Brandon Mount Sinai.
Glenn Martin, member.
Patrice Wallace-Moore. Thomas Akers, member.
I'm representing Sinai.
Yeah.
Quincy Bernstein, council member.
Scott Castan, Jewish Board.
Tino Hernandez, member.
Who's up? Susan Lorenzo,
Donna May DePaula, member.
Okay, you want to introduce yourself?
Edison Alvin, Director of Communications, Oasis.
Okay, welcome everybody. It's nice to have you all together. Before we start the formal agenda, I just want to extend a huge thanks to Pat Zuber-Wilson. I think all of you know that Pat has been the co-executive secretary of the council along with Lisa Rademacher on that OMH side. Pat has done a terrific job helping make all of this run so smoothly. And now there's congratulations in order that she's now the Associate Commissioner of Prevention. So we wish her great luck, and we know she won't need it in that job, in that new position. But it also means that she will no longer be in the position with us here as co-executive secretary. But we are delighted that Tracy Collins is the new co-executive secretary. And Tracy's been terrific too. So Tracy, we're looking forward to working even much more closely with you on the council.
Thank you, Paul. I appreciate that, and I look forward to working with all of you as well. Thanks so much.
Great. So it's wonderful to have you, and it was really terrific working with Pat in that capacity here.
And we'll pass along your very kind words to Pat.
Okay.
Well. Thank you.
Please do.
Will do.
Please
Thanks.
do. Okay, and now we will. We need to approve the minutes of the last meeting on January 11th. Are there any? Well, first, is there a motion to approve? Is there a second? Are there any comments, corrections? Hearing none, all in favor of approval, say aye.
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 Any opposed, any abstentions, passes. We have approved the minutes. And now we go to the highlight of the day, the commissioners' reports. Whichever of you would like to go first.
Okay, well, thank you. Okay, so I guess today what I really want to share is, the budget, information on the budget. In general, our budget is not a bad budget. It's a fairly good budget. It's a, flat budget, but it will allow us to continue to do some of the things that we have already started and allow us to move forward with additional stuff. So let me get through the numbers type of thing. So, our budget is $808 million, and it has $138 million for state operations. It also has $580 million for our aid to localities, which again will allow us to continue stuff that we have in the pipeline. That $580 million also includes some of the monies that were put in last year for jail-based treatment. That 3.75 and that 1.5 for the ombudsman, mental health, and SUD ombudsman office. So it's fairly a stable budget moving forward. Capital, the same thing. We have 90 million, which shows like a 10 million in reduction. But that 10 million was reappropriated, and that's what we're using for the 40 beds that we just finished. I believe we already announced the winners of the 40 beds this past week. If not, we will. So it's, again, a standard budget, no cuts, no reductions, no cuts in staff, no elimination of programs. So it's a fairly good budget for us. It also includes the 2% funding for title-specific salary increases. I know a lot of folks wanted 2.9 as part of the COLA. We got a 2%, but there will be 2% allocations. One in January of 2020, and then in April of 2020 for the same amount. So something's better than nothing, especially during these really difficult times. This was a very difficult budget, by the way, not just for us, but in general for the state. There's funding to continue our commitment to the minimum wage, which is also good. And so in addition, the legislature added $5.5 million for one-time funding for several initiatives in our budget. And I don't think I have to sit here and outline them to you, but there are three things that I do want to point out that are very good for our system, and that is that they added an additional $1 million for the jail-based SUD treatment and transitional services. So, but that's only one time. So some of you may see that there's 4.75 million. 3.75 is what's in the base, and that was put in the base last year. New is 1 million, which is only one time, okay? And then we also have the 2 million that always goes in for SAPIS workers. That's something that goes on every year. And this is another thing which I found very interesting and we're very excited about. Our new chair, Hartman, put in $350,000 for a loan forgiveness and scholarship program. So I think that that's going to give us the initiative to really start looking at how we could expand, professionals in our system, how we could attract more professionals into our system, and even maybe look at how we could do some funding for higher level education for some of the people that are working in our community-based organizations that perhaps cannot afford to get that higher education and so on and so forth. Now, $350,000 is not a lot of money. We understand that. So we're currently trying to figure out how to best use that money, but to use it so that we could get the biggest bang for our buck, but more importantly, show that there's a need for stuff like this. So we may not want to do nickel and diming people, giving $2,000 here, $3,000, because that's not going to do anything. We're going to look at maybe doing bigger things, fewer but bigger things that we could prove that we need to continue funding in next year. And I think that in terms of dollars, that's really what's in our budget, but I need to draw attention to some of what we call the articles that prove that while they may not have any dollars attached, there are, policies, implications that really are going to have a tremendous positive effect on our system. So some of the things that are in there, let me just, so I keep in tune, is that there's language that allows immediate access to medication-assisted treatment for opioid use disorder by eliminating prior authorization for preferred formulary versions of medication, okay? It also allows SUD treatment to start and continue without insurer interference. It prohibits prior authorization and concurrent review for 28 days for inpatient treatment and for 4 weeks not to exceed 28 visits for outpatient. This is new, okay? But this is what we've been hearing, some of the issues we have, that we have insurance companies, person goes in, is there for a week, and they're already saying, we want a concurrent review. Now they cannot do it until the 28 days, which is what is required in our inpatient. And then, 28 visits for the outpatient. So we're hopeful that that's going to really have a good impact in our system. It also allows OASIS to designate our locator tool that everyone I hope is familiar with as the standard utilization review tool for all in-state SUD treatment. And I believe the big thing here is that before we require the Medicaid managed care entities to use it. Now we're asking also, we're mandating the commercial insurance to do it as well. So that's going to also be helpful. There's language that establishes co-payments for SUD outpatient treatment services equal to a primary care doctor's outpatient visit. Again, that's going to bring us closer to, not closer, but it's going to bring us to parity with other healthcare entities. Right now, in our system, if you went in, technically, you would have been hit with a copayment, 3 different copayments for 3 different services, which is not the way it goes in primary health or other healthcare. So now there's only one that will cover all the services that you get. It also limits
it's still each visit. They can still have a copay for each visit, because our treatments tend to be ongoing, whereas people see their primary, a couple times a year. So.
Yes, but it's not for that day.
No, I understand. It's a single day, but it's still, unfortunately, still adds up. If somebody has a 28-day or whatever outpatient series of visits.
Okay, but then there's also, it limits the copayment for SUD outpatient services for a single copayment for 1 treatment visit. In other words, there's 2 things here. There's one that brings us into parity with the outpatient regs, right? Regular primary health. And the other one that looks at what is that copayment that you're charging. It has to be in parity with primary health. So there's 2 things, okay? I hope I'm explaining it correctly. If not, I don't know if Rob's there or somebody. He's there? Okay. He could explain it, but that's essentially what it is. It's 2 different things. It also requires, insurers to cover naloxone for those covered under an insurance policy. It prohibits insurers from retaliating against providers that report insurance law violations to state agencies. I mean, we've heard that some people who complain about their practices, they're thrown out of the network. They can't do that anymore. I mean, they could do it, but then we'll go after them. It enhances protections to stop New Yorkers from leaving New York State for SUD treatment. It enhances the mental health addiction parity law compliance by requiring first to provide more detailed information regarding their efforts at compliance and to make such information public so that everybody's aware of what they're doing and so on and so forth. It also requires hospital emergency departments to have a policy and procedure in place for providing medication-assisted treatment to patients at discharge. This is the whole piece on induction starting at the EDs. So start induction on the ED, and if you don't want to follow that person on the 2nd or 3rd day, you must have a plan where you engage that individual to get the 2nd, 3rd dosage in the community. And that's huge for us. We've been really trying to get that to happen. I don't think I have to explain why, because it's a captive audience that we always have, and usually they're just there. They stabilize them supposedly, and out they go, and we know what happens. It also requires Medicaid coverage of court-ordered treatment for OASIS certified programs within New York State, okay? It extends the ambulatory patient group rates through March 2023. And so, let me see, what else? Okay, there is also a tax credit for employers who hire individuals who are in recovery from SUD. This will be managed by OASIS in conjunction with, the Division of Finance, not finance, DFS, taxation and finance. And essentially what it is a $2,000 tax credit to an employer per individual that they hire. The specifics we're still working out, in terms of who's considered an eligible employer, who's a person in recovery, all of those things are being worked out as we speak, yes.
But is that a concern, at least theoretical, about, it sounds like your employer that can help you. Why would I volunteer to an employer that I have a substance use disorder and I'm in recovery if I can get a job with him without saying that?
You don't have to.
What I'm saying is that it sounds like in order to the employer to get the tax credit, I tell them I'm in recovery. Well, why does my employer need to know that, generally speaking, about my health condition?
He doesn't, and therefore it's up to the individual. The idea behind this, it's up to the individual if they want to disclose it or not.
Okay.
The reason I think it's a great idea is because too often in our system, we tend to do things, but we keep people within our system, SUD only. We don't show that people in recovery right now around.
Exactly.
But I'm saying, we need to branch out. We need to try to get people that, have had an addiction, who are stable, to know that they could branch out, they could go into, the private sector. They don't have to stay within our system. And they could probably do very well. It's up to the individual if they want to do that. We're not forcing them. We're making it an option there, and we're giving sort of like the gateway for providers to want to hire our people. And my experience is a little differently. What I hear is that some providers don't want to hire because they're, for whatever. But it's not because the clients don't, or the individuals don't want to share their experience. There's nothing to be ashamed about, sharing whether you're in recovery or not, So I think it's a great way to try to branch people from a certain section where we always maintain them into a different level of employment.
I have a question about that. Sure. So I'm sort of curious because I think we're all familiar with the law of unintended consequences, and I'm wondering to what extent this tax credit, because I somehow or another got the impression as you were explaining it, that the focus was towards providers, but I guess the focus is industry as well.
No, it's not providers. This is not our providers. In fact, our providers are not eligible for this.
So employers.
Yeah.
So is there some vision by OASIS about how we might evaluate this at some point down the road to see if we get the benefits that we are asking for and that we don't have the negative consequences that sometimes can occur? Because I can see how in some cases that an employer, unfortunately, and it's true, a terrible employer may ask a question because now I'm motivated because I get this tax credit.
Right.
If I in fact find that out and I hire you, then that may very well then unintentionally out the employee. The employee may not want to say anything about it, but sometimes employers have this ability to in fact obtain information.
It's illegal to ask that question.
That is true. But we know that things happen even though it's supposedly illegal. So I'm just asking about evaluation.
No, I think this is great that you're great. Look, we haven't written this out. We're in the process of figuring through the process. So I welcome your input, and stuff will come to you as the governing body anyway. And if you have ideas and questions, I really welcome them, because this is very new. So it's not like we're following any patterns here. And so we're also challenging. We want to make sure that we address all of the issues and concerns, and we set it up in a way that we won't have the unintended consequences, and if we do, that they're not as bad. So.
One thing that I think would be, that I would recommend, is that you publicize the program.
For the people who
You don't
volunteer.
necessarily ask the individual, the people who can volunteer for it. That would be one. My other concern would be, I'm okay with Oasis, given that you're in the business. So to sort of know the identity of the person that's applying for the program. But how about taxation and finance? Would the company have to demonstrate that they have an individual, that they identify the individual to qualify for the tax credit?
I think the monitoring, yeah, and we're very clear that, confidentiality is huge. We have to abide by all that. We're still in the very early stages. Tax and finance has to monitor the dollar amounts. They don't necessarily have to know all the details of it, but because it's a tax, break, sort of speak, that's, they have to be part, but they're not gonna be part of the actual knowing of who it is, or, I think that's up to us to evaluate and approve and go for it.
Us being Oasis.
Oasis, yeah.
You also mentioned that this is not for OASIS providers.
Right.
It's for non-OASIS providers. Right?
Right.
Okay.
Well, I guess it's for profit. I know, I suspect the whole thing is a great idea, to try to incentivize employers to take people in recovery and to not just keep them within the SUD community, but it's great. The concerns just being raised are obvious, a lot of operational concerns that we all have, and that's it.
No, they're good. I mean, I think it's better to really talk them through before we go down too far, so that, we could address any issues that may come up or that we know are very, obvious.
I concur. I think it's a good idea. It would be good to sort of get input from people. Flesh out the plan.
Yeah, I think the input's important, but generally, and again, not with our populations, but tax incentives, but it's like hiring disabled, again, the confidentiality issues and things that we have been very successful. So I think that's where this is coming from. So when you can do that, you can really get employers to take people, and on the physical disability side, people aren't as reluctant to disclose. So I realize there's all this other stuff with our guys, but I think the potential here, if we can do it right, is good, because I think it's a way to get the outside employment world involved, as long as we watch out for all the things we're bringing up.
Yeah,
Here in Albany.
Yeah.
Paul.
Okay.
Paul.
In Albany, go ahead.
Yeah, I'll share an experience. We have a number of employers in Jefferson County without the tax credit that are actually seeking out some of our individuals who have completed our programs, because they have a track record of being good workers. And particularly one of the owners of the Wendy's in our area, Wendy's is looking at a fresh start program, a second start, giving individuals that have kind of got off on the wrong path and opportunity. He has come and met with our managers of our community residential program and our employment and education counselor. And we've already got a number of individuals that have started in the program, and they train them not just to cook fries and burgers, but how to put them on a management track that they get exposed to all aspects. It's been a very positive. None of them have ever felt that they were in a bad place having to share that they were associated with Credo. In fact, they were proud to be able to do that. And at both Wendy's as well as a local lumberyard have been asking when you're going to have any other individuals that might be appropriate to come to work. So this will just encourage that type of support, I think, in our communities as we go forward. So kudos for targeting that, Commissioner.
Good, excellent. Thank you. Thanks. Any other questions around the tax? Okay, so Jen, just two other things, or three other things, you know. As in the past, you know, the budget will allow us to continue the collaborations we've had in the past with DOH to further support our work. The bulk of the funding will be used to help continue the transition to a Medicaid managed care environment. So funding is as follows: $5 million for residential redesign, startup funding to hire clinical staff, Part 820 conversion. $5 million for designated vital access providers to stabilize providers, moving funding and operations as the state continues to transition to Medicaid managed care. The reinvestment of up to $25 million relative to the reduction of the health and recovery plan. It's also there to target opioid treatment programs and peer services. And there's $20 million for year 2 support of the Behavioral Health Care Collaborative, BHCC's, the Value-Based Readiness Program. You know, and for those of you who sometimes I confuse them myself, it's a 3-year program which provides funding to 19 selected networks of behavioral health providers called BHCCs as opposed to BCCH. So I'm the first one to say that I confused them myself. So these funds are used, you know, to assist and develop the infrastructure necessary to prepare for BBP contracting, so on, so funding. I think that that's really the bulk of our budget. As I said at the beginning, you know, there aren't additional dollars. We have a somewhat flat budget, but as you could see, you know, these policy changes and regulation changes I think are going to take us to a level that adding millions of dollars to our budget would not take us. So it is a good budget for us right now. We will continue what's in the pipeline. We will continue with our, you know, using our federal grants, you know, which I don't want to get into too much, but you know, we're getting federal grants where we're using it to do a lot of innovative mobile capacity, you know, centers of excellence throughout the state, and we're going to continue to do that. So we have a lot of good announcements coming out very shortly, in addition to just what's in the budget, how we're using our federal dollars. So in essence, I think it's a fairly good budget.
Any further questions?
I just have one, and maybe I missed it in one of my naps that I possibly take every now and then. There was some language that I kept seeing going back and forth in reference to the managed care calls, like that there was some language in there that talked about 28 days or 14 days that a review. You can say that, right? So is that effective January 2020? When does that become effective?
I believe it becomes effective as of now, the enacted budget.
January.
Yeah. Oh, January, okay.
January, okay.
Next January.
January 2020.
Yeah.
Okay, all right.
Thanks.
Paul, quick question for the commissioner.
Sure, go ahead.
So any predictions on the marijuana legislation that's didn't make it in the budget and has been debated regularly? Gotta ask it.
Yeah. Okay, Rob, you're on.
I predict there will be a conversation about it between now and the end of the legislative session.
Take some risk.
We'll wait, Rob. Okay. You see how
I think you're right on target, Ross.
Yeah, I would agree. Well, there'll be conclusion of it.
the session will conclude at the end of June.
Thank you.
Thanks for nothing, Rob.
I'm not sure anybody's crystal ball is any clearer than that anywhere in the state.
No, in all fairness, there's a lot going on, and there is a lot of discussion going on. And as Rob indicated, I think hopefully we will hear something soon. It's a lot of negotiation. It's not as easy as people think. Sounds like it.
No.
Really is.
It's not.
Very complicated.
New Jersey's still stuck. New Jersey's stuck.
Yeah,
They've been stuck for a few years.
Yeah.
It's stuck since I've been born.
So the council may be interested in knowing that my good friend here, Glenn Martin, and I.
Good friends?
Yes, we. Anyway, we actually, this matter came up for a conversation during the Public Health Planning Council about medical marijuana. So the distinction between the two, and the question came up about how the department intends to evaluate the impact. Allegedly, they said they do intend to evaluate the impact, but they're not yet at liberty to share how that's going to occur. And they shared with us information about whether someone who is receiving medical marijuana outside, for some reason outside of a substance use disorder, whether they would appear on iStop. So the answer is that they would appear on iStop if it's for a non-SUD reason. But if it's for an SUD reason, they would not appear because that's not on the iStop. So that's important information that they shared with us, because we wondered, as a practicing physician, to what extent we'd be able to be comprehensive in providing care to our patients based on the information that's available to us.
Interesting.
Okay, thank you, Commissioner. And now, Commissioner.
Hi, thanks. Many of the things that, I think one of the really good things about this budget in terms of a lot of parity and some of the other issues is we've worked very closely with Oasis, and actually Oasis was the leader in many of the initiatives over time that have had those kinds of impacts. So a lot of the stuff kind of comes over to our side, so I'll say that kind of briefly. But just to give the overall similar situation, that basically our budget is basically whole from what it was before. This year we didn't even get any staffing reductions, which is good, and I think which made the unions pretty happy in terms of the budget. So the budget is pretty much the same. The state aid is pretty much the same in terms of the dollar amount. Slight increases in state aid because of the projected increase in wages. The 2% it covers mental health as well. Direct care, and then 2% professionals, 2% next January for direct care, and then next April, 2% for direct care again, and 2% for professionals. So that will affect our budget, and that's increasing some of the state aid. So basically, we're pretty flat, but those increases are in there. So it means that basically there's no significant difference in the base money that's in the mental health system. Now, a couple of things that were very important in the budget. One is the issue of housing, which is a huge issue across the state, and one of the issues is obviously the stipend for supportive housing. There was a lot of advocacy in the budget to try to get that stipend up considerably. We only got the $10 million that the governor had put in the budget. The legislature didn't in the end add any other dollars. I think it is important, though, to remember that there's been $10 million a year for 5 years. So that means that overall, over that period of time, there's been a $52 million investment. There's ongoing dollars that sits in supportive housing. There's more that's needed. Everybody knows that. But there is that ongoing. Also, all new housing is at a higher level. So we no longer have any housing at the old legacy rates. And some of that varies anywhere from 20 to 25,000 on the state side. So the newer housing that's coming up is at the higher rate, and there was a $10 million increase, which brings New York City, for example, I think close, almost at 18,000, but not quite. There was also, though, $60 million, because sometimes it's easier to get capital dollars than other dollars. for housing for the bricks and mortar of housing that exists in some of our community residences, et cetera, in the community, to help fix some of the infrastructure, the physical infrastructure. And that 60 million is in the budget. So that was an ad that was important. That hasn't been in for a long time, and that will help keep some of the housing structure going. So on the housing side, it is also important to know that there are another 2,600 slots in the pipeline next year that are going to come up for supported housing. And also, we've been getting in the Eastside housing approximately 30 to 30, somewhere over 30, 35%, creeping up to 40% of the Eastside supported housing for mental health. That's a little disappointing. In the past in New York One and others, it was over 50%. So there's an issue about that. It probably has to do with some of the finances, et cetera, funding, but we're pushing to get more. However, there was a little money left over. I shouldn't say left over, but it wasn't absolutely used in the first round of Ishai funding. We got permission to use those dollars to put out for 500 more supported apartments. So that basically to help, because mental health has been down on the side of getting some of the bricks and mortars of Ishai housing, not to lose the money, but to use it for supported housing. 250 of those will be for forensic slots, because it's very important that we increase the ability of the forensic, and 250 will be general slots across the state. So those RFPs are out. I think we have a little trouble filling some of the forensic, it's pretty high, it's about 25,000 per slot. So I think we're going to be looking at maybe reissuing that. The other ones got all filled with RFPs. Forensic, as usual, is tough sell sometimes, but it's really critical for our guys leaving the forensic system.
Expansion.
Yeah, it's expansion. So in other words, so we are still, the housing is still growing. There's also a lot of supports. I guess probably everyone's had the opportunity to read some of the newspaper articles on the adult home issue, and on moving some of our clients from adult homes into supported housing, and the unfortunate thing that was done by Politico and the New York Times. Those were cases, quite frankly, that sometimes we don't do. I have to say that I think to some extent we probably could have done a better job with some of those. However, what often gets lost in the push here is there are over 800 individuals that have successfully moved and are doing really, really well in supported housing just from those adult homes. The 5 or 10 cases that they found or that they highlighted were very sad, but a lot of work was done on those cases, much of which wasn't in the newspapers. I can tell you there was a lot of case finding, there's still no case management, et cetera. They were very, very difficult cases, and ones which unfortunately individuals had lots of challenges. A couple of them did go back to living in an adult home. Others are now successfully living in the community. So I think people have a right to try, and I think that we have the responsibility to help them try as much. But the housing providers have done a great job. They truly have, and that was not a fair. Anyway, in response to that, there is another $10 million, which is going to help the housing providers, I think, and that's going to involve things like pathways to home teams. And increased care management. It involves everybody in those programs will have Health Home Plus. And so there's a lot more wraparound and a peer bridger program, which will be working with about at least three peers per adult home, who will be working to help bridge the movement into the community. So there's investment in the budget to further assist housing in doing the job that we've asked them to do with these individuals. I think it's so important to appreciate that this is really a wonderful opportunity for most of the individuals who've never been to adult homes. There's a couple that are okay, but they're really kind of not good. They're kind of warehousing approach. They're not good for our clients. And individuals can live their lives there. So to really have this initiative to be helping people live and move out into other, it's a transition. It's different to be in the community than to be in an adult home, but there's a lot of effort going into this, and I think overall the success rate is really very, very good. So just to keep that in mind. So that money was also in the budget. So, the housing support continues. It's not everything that everybody wanted. I know that it's not where we want to be in terms of some of the housing rates, but at least the new housing coming up is better. And I think that basically, I would just ask the advocates to continue to work on this, and we'll be working on it too behind the scenes over the course of the year to see what we might be able to come up with as a reasonable plan that will go out a couple of years perhaps this time in terms of commitments for housing, so you don't have to fight the fight every year. But we'll see. New York State, just keep in mind, we have almost 45,000 supported units of one form or another for the seriously mentally ill. It's a huge investment, more than any other state in the nation. Need more, but it's a huge investment, so you have to kind of just keep that in mind. Okay, so there's housing. The other area of it was in the budget is reinvestment. We do have a commitment for any more beds that close to put $110,000 per bed in the community. We are expecting not to be closing as many beds. If anybody watches all these reports that we give to the state legislature, which are tomes of paper, exactly what we're doing, the whole process has slowed down significantly. It's slowed down because we're being very careful about closing the beds. And we only close them if we have a waiting list of no more, or by waiting list, I mean, you're ready to get in no more than 2 weeks and 90-day vacancy, 90 days of vacancy. So you have to be able to have 90 days vacancy, no waiting list, and the other waiting lists we're trying to keep at 2 weeks to get in, the day you're accepted. So we've slowed down because I think what's happened is that we've been able to close a number of beds by moving individuals who really were ready to go and get them out into the community, and now it's getting more difficult. We have a large cohort of patients who've still been in our system for many, many years. We don't want to continue to grow that, but it's a challenge to move those individuals out. They need lots of supports to be successful. The good thing is when we moved our long stays out, and by long stays I mean people over 2 years, some over 5 years, some over 10 years, our return rate is less than 5%. So we've been really careful with these individuals because it's really, their lives have been focused on our state institutions. But it's a lot of work, and it means a lot of wraparound services and a lot of very cooperative and helpful housing providers who work with us. So basically it's working, but it's slower, and we're not expecting to be closing the number of beds that we had before. Probably this year, maybe, we'll see how many, but probably no more. My book, probably ultimately no more than maybe another 150 over the next couple of years at the most, leaving us with approximately 2,200 civil beds and another 2,200 adult civil beds, another 300 kids, and another 1,000 forensic. So that's probably where it's going to stay. But we are in the process of working on, the good thing is, that the number of admissions, while some people still think we should be admitting more, the number of admissions have stayed about the same as the beds have come down, which means that some of those long stay beds eventually become no beds, because now we have some reasonable level of turnover, become real beds that can service the community. So I think that so far so good with that, but it means that we probably won't have as much money for reinvestment, which is too bad. But we put about, in the last 5 years, $100 million out there in reinvestment, and the good thing is track all the money, so you know exactly where it's spent, where it is. We report to the legislature on it, so it can't be taken away. So the $100 million is really invested in clinics and mobile crisis, home-based crisis services for kids, and some beds as well. So it's a real $100 million that's been out there over 5 years, and I think especially in certain areas, the state's made a big difference. So those are the major, I think, money parts. The COLA, we weren't as happy with. The parity, I have to kind of say again that this is, for mental health, I think this is really getting into this whole issue of controlling what the managed care companies do. We haven't been as aggressive at doing that as Oasis has or as successful. The big thing in the parity is that now the medical necessity criteria will have to be reviewed by OMH. And we will be sending back to the plans what medical necessity criteria we feel is not appropriate. If you remember, they've never had to share it before. It was all in folks proprietary. This is just how we do our business. Nobody has the right to know. So now they're going to have to be submitting all of that. Now that's a big burden on OMH that we've got to kind of get set up. But we intend to spend a lot of time looking at these plans, and we're hopeful, although I'm not so sure, because we've got to figure out how to get the funding to do this. We're going to try to work on something in the equivalent of the locator tool that Oasis came up with. And I think we can be informed by them when we get these plans, when we get this information. And then we're going to really work on trying to come up with a tool that would really be workable, that we could say, these are the standards you have to have. So we're going to give them standards they have to have. And then maybe we can eventually move the standards to a tool, if we can say this is what we want. This will take a while. This isn't going to happen overnight. But the review will happen immediately in terms of looking. And this, I think, should help us significantly. With the main thing they do to us is, cut off those days that you're allowed in.
That's in the continuing review process.
Yeah, exactly. So now that's in the medical necessity criteria. So the medical necessity criteria drives their review process. So if you can catch them at the medical necessity criteria, you can deal with the review process. So that's a critical point. And, I've always thought there's this magical number of a 10-day, whoever did it, I've never seen a double-blind study that shows an acute inpatient service should have a 10-day length of stay. It's a magical number.
There's a lot of data that says it takes at least 3 weeks to stabilize.
Well, exactly, and if you switch a med, did you ever, but if you switch a med, it's what takes 4 weeks to work. Exactly, what are we doing, So the reality here is very interesting.
And also, we're also disrupting people's care course because we have to send them to state beds and
absolutely,
which is
nuts.
And they wouldn't necessarily need that.
I absolutely agree. So hopefully this is a big inroad. The second piece is modeling again after a lot of what Oasis does. We couldn't get this for adult yet because it's a bigger number, but we got it for kids. That basically there's no prior auth for kids inpatient admissions, and 14 days kind of no utilization review. So that's a big help for kids. Also this year we got a 25% increase in the rate for kids beds. So that's a huge jump. That should be realized
That's
soon.
reduces 90% of the cost.
It's fascinating when you look at the I forget what it's on the med-surg side. Everything pays about 85% of something, whatever it is. I think it's paid something. Psych is paying 62, 63%. It's horrible. It's a huge parity issue, but you can't go at the rates directly because that's some kind of antitrust nonsense that's out there. So you have to go at how they determine the rates. Rhode Island did the most impressive thing on this. They went out and they found out that the way they were determining their parity, the way they got them was basically they were determining their psych rates a different way than they were determining the rates for med-surg. And so we're going to look at the same thing. That's going to be one of the investigations that's going on and see if we can get them for this. But this brings, I think, probably up into the 75, Emma would know, probably 75% of whatever for kids. Adults still low, but we did get 5% up for adults. So that at least pushes up, adult up. There's also a commitment to look at the rearranging of the rates. Now, that's always tough because usually when you rearrange rates, it's one pool. Nobody wants to up the overall pool, so you need to take from somebody. And med-surg is fierce on this. It's very hard to get anything out of their own hands. But there will be some relooking at the rates. And we can't go down, so maybe they're going to look at the rates. We can go up a little bit. But the goal is to get us up eventually to the 85% range like everybody else. But it's creeping up. So it's going to be good for kids, and it's going to take a little bit longer, I think. And our APG rates, again, it's just like Oasis, are embedded in the budget, and that money will continue till, I think it's 2023, so it's a long one, so then we don't have to fight that battle, as we come along. So those are the and the co-pays are the same as well as for primary care, as well as for substance use. So having those things, and then the other big piece is that there's the money, we were afraid we would lose this, the money to look at the enforcement of parities in the budget, because, you can write all this stuff, and as we all learned from the federal parity laws and the other parity laws, it's all written, just nobody does it, So the reality is that there's money now in the budget to enforce it, and some of that's going to GOH, some of that's going to the Department of Financial Services. And so there's actual money to have people go out and try to do the investigation you have to do. And the other big thing is networks. Networks, phantom networks that are make-believe, and how do you kind of really, monitor that? So we're going to be doing that. Also, the other legislation, which wasn't in the governor's budget, but was there, is the transparency legislation that they have to now report all kinds of things, the managed care companies on the websites, et cetera. So that's good. So I think that there's a lot. I think this is the biggest push. The ombudsman is again funded. The ombudsman's great because, and this one, please get the word out. We're going to be sending out a letter to all the practitioners and to the private practitioners. I think, our providers will know, but I think there's this whole group of individuals serving the commercial payers out there who get these denials, who throw up their hands and say, what can I do about it? Because they're in private offices, even if they're in group practices, it's enormous to kind of appeal this stuff. It's just too much. So that the individual either doesn't pay or they leave that practitioner, et cetera. Now you can go to this ombudsman and say what your problem is, and the ombudsman will work, if you want the legwork, to kind of appeal. That's critical for the clients, but also the providers can go to the ombudsman. I'm saying this. If you're a provider and you're sitting there and you feel that this is really an egregious disallowance, you can call the ombudsman and say, I think this is, and they will help. There's lawyers in that office, there's others who've worked in commercial also. Yeah, everything. So they're there really, it's a big hit on commercial because commercial is one of the hardest. So we're trying to get the word out We're going to send letters out to private practitioners, because I think that, you know, those guys out there need to know that they can call and get some help here when they get these crazy referrals. So I think all this coming together is really very powerful at this point in time. And I hope that it will, you know, as I think Barney said, I think this kind of stuff can have a huge impact on the system. You know, and I think it can have a huge impact, especially for us. One of the big issues has been kids in the lower to middle class, and getting those youth to be in their insurance companies. They've got insurance, they just don't pay. You know, so I mean, and that's crazy. So I think that there's a lot of work that's going to be done which will help support that. So we're looking forward to that.
I have a question about the foster care kids, because they're going to go into Medicaid ministry for the community. So one thing that happens all the time is that we suppose in the public system, we keep kids in hospital beds because we don't have a good place for them to go. We do feel that's part of their health, but, and that's their harm. Like the kids system really need to think about that issue and how we manage medical necessity around that.
Yeah.
Because otherwise they're going to go to the children's center, which is already a total disaster.
Yeah. And I think,
any help from that?
yeah, we're going to have to look at the disallowances for residential and that kind of stuff that comes from a lot of the.
Well, there's a lot of cost sharing. You know, we'll hold the kid until they, because sending them to a bad place is going to make them sicker.
Some of the biggest suits on, and then some of the biggest suits on parity have been about that, residential treatment across the country. Whether it's residential treatment for eating disorder was a big one, where they were just denying it.
It's not even residential. It's like if you have to wait another week to make sure there's a foster family that's appropriate for that kid. And otherwise you're putting them into short-term residential, which is incredibly difficult.
Yes. Yeah, I don't know that much about the foster care system, I'm not, but they are in the Medicaid system, so they should be under the same kind of hit in terms of getting these things done that the managed care companies and others are. So we should look at that. I don't know about it, but that would be an important thing to, because that is a serious issue on the foster care side.
I happened to attend last evening a meeting of the Manhattan Central Medical Society, and I was wondering, it sort of brought to my attention as you were sharing your comments, to what extent is the department involved in educating the medical societies about the availability of services? The reason I raised that is that, as you know, we have a adolescent program, and one of the pediatricians almost brought me to tears when he said that's kind things about a program, that he referred some of his patients to a program, and that's great press. And I just wonder if there's some effort by OMH to try to get that word out to the medical societies that are mixed specialties, that might be useful for them to hear about the services that are available, particularly around adolescents and teens.
Yeah. Yeah, no, that's a great idea, and I think we have to do more of it. You know, we've been asking, the first time we've actually asked for the list of the doctors is relative to this parity issue, but I think you're right. I think we can also, you know, and it's how do you reach into the practitioners that aren't in the provider, the public system. And I think from that we need lists and stuff of people and so we're going to be working with the medical side to see if they'll work with us. You know, when we give them everything to send out, we're not going to try to use it on our own, but we need to work with them because there's a whole bunch of providers that we don't get to. And they do have the lists of them because I know that I did a joint letter on depression with Dr. Zucker and it went out to everybody, all docs, for example. But then there's also the other levels of practitioners too, you know, the social workers and psychologists out there and work with their organizations too. So yeah, it's a great suggestion and we're going to be doing more of it. It's dawned on us with parity, but it's bigger than that in terms of knowing what's available in communities and sending it out in a way that they can digest. So we have to talk with their societies about what to send out, how to send it out, that docs won't just click it off, you know.
I'd be happy to assist.
That would be great. That would be great. No, that's really exciting. And that brings me just to the last thing in the budget, which is kids, that the kids are fully funded. The kids expansion, which are the 3 spa services that became available as of January, and all that are fully funded going forward. This was a bit of a battle because if you remember last year at one point everything was delayed for kids, partly when there was a huge crunch in the Medicaid dollars, but now it's there, it's fully funded. And by fully funded, I mean there's an expectation that it could grow. I sincerely doubt it will this year because it just takes too long to get these things started up. But that these kids services could grow by 10 to 20 million a year, branching out to as much as 60 million after a 3 to 4 year startup if we do it right. I think it'll take much longer than that. But there is a commitment to do that. And the big reason why there could be more spend is that the criteria for using these very intensive home-based services is no longer that you have to, it's almost like the always fail first. You have to have been hospitalized, you have to be on the verge of hospitalization, you couldn't get it. But that criteria is moving down to certain other risk or severity criteria, so you'll be able to use the services much more in a preventive way, not just in a something really bad has happened way. So I think that when we get these up and running, if we can really get the community, it's hard. The biggest issue is they're billed differently. So you've got to, the managed care companies do work with the bills, and the providers to do the bills. But once we get it flowing, it is a good design which will provide much more intensive stuff for kids in the home. And some HCBS-like service for kids in the home.
You know, all of that is great, but I just have to, we have to point out, as long as we're dealing with the workforce challenges that we have, it's going to be very hard to staff up those programs, considering that the programs that we operate currently have so many vacancies. You know, the 2% for the hundreds and 200s, it's not enough. You know, it creates all sorts of inequities in agencies, because some of us also have those CFS and HRA and HUD and all that, but which is why the COLA clearly would have been much a better way to go. But I do think, and I would hate for us to be in a year from now saying, oh, we didn't spend all this money.
Yeah, I agree.
And then somebody take it back because we weren't able to hire the psychiatrists and social workers and case managers and direct support personnel who have to do all of this work. So I just think, you know, I understand the politics and, you know, all of that, but I do think that it's we really have to deal with that issue, because otherwise the erosion, even with the wonderful new programming and parody stuff that everybody's doing, both in Oasis and Orange, it's great, but there's nobody to do parody work. We're just going to be left with, you know, and you know, and on top of it, then the housing issue, you know, just keep it, just, you know, people, and then the programs, but even the services, we just struggle, and if you make the same money at Starbucks, if you're direct support personnel, if you can make more money at a managed care company, you can do private practice. I mean, we're not a competitive employer, particularly community-based agencies, maybe the hospitals have a little bit better. They're not.
No,
My colleagues all work for the state. So anyway, it's a real, it's heartbreaking.
I know, and I think, you know, yeah, I agree, you know, I know. The issues of the politics around, you know, the COLA, et cetera, all I can say is that I think it's important to keep the voices being heard, you know, certainly, you know, we make a case, everything, but it's difficult times. Partly, I think, the revenue, the massive decrease that they're so concerned about in revenue to the state, it happened, maybe it'll be better this year, the stock market seems to be better, but you have to realize at the time of the budget, that real hit to revenue had come from the fall of the stock market at the end of last year, where everything went down for that quarter. So there was a lot of anxiety about the budget and what, and putting certain things in that become very long-term spends, like COLAs, et cetera. So I think that, you know, hopefully if the year looks better this financial year, you know, I would continue the advocacy that you have, but that hit probably the worst time for everybody to get nervous about what was available, and I think that, so that didn't help with trying to push at this point in time. I absolutely agree with you. We have the same, you know, state system. I know you think we pay better, but we have massive problems too with getting the workforce. It's because we have tough jobs. You know, we may pay a little better, but you know, we have some of the most challenging, difficult clients to deal with. So it's really tough to get people, and we have the same issues. I think it's an underpaid workforce universally for a long time, and we're dealing with that legacy. Getting it up to where it should be is huge, because the legacy of being underpaid for years. I mean, the same struggles we have now, I had 20 years ago at the Health and Hospitals Corporation.
And we're still having them.
And while you'll go up a little bit, you know, you'd have these periods where some of the salaries would go up, and for like 5 or 6 months were actually just a little bit competitive with everybody else, and then kaboom, the other salaries would go up. and you'd be back where you started from again, you know, oh my God, and everybody would leave to go to across the street to NYU, or when I was in Belleville, across the street. It was just this kinds of stuff. It's a constant struggle. That doesn't mean that it should be, but it is. So all I'm saying is, we keep fighting the good fight to get the kinds of dollars in. I do think that we're working, it's separate. The dollars, yeah, if you're going to graduate, it's also getting the schools to hopefully, get people interested. Because even though the salaries are low, I also think that, I know in nursing, for example, they don't train any psychiatry in the nursing training, by and large. It's not there. So so you pick that out of the hat, when you leave? So why would they choose us? They don't even experience us. So, we're working in a lot of nursing schools to at least get some rotations through our hospitals or our clinics, so the nurses can come out with at least thinking about psychiatry. And then social work, again, some of the training programs are not up to what kinds of things we do today. So they come out and they don't get what they think they're going to get, So I think that, some of it becomes the recruitment, and which we're trying to talk to some nursing schools and social work schools, et cetera, to get people ready for our workforce, because the professionals, the schools are not often where we are.
Right.
And so they come to us and then they leave. So it's complicated. It's money, I think it's training. And then, unfortunately, it becomes a morale issue too. If you don't have enough people and they're working too hard, then it becomes morale and people leave. So there's a lot of things that have to come into play, but we will continue to fight for the.
I just want to, maybe it's not so bad.
What is it about? Yeah,
no.
So it's something.
You're right in terms of undergraduate, in terms of training, they really have to learn everything, and psychiatry is the last one on the list, because most of them are scared to move into psychiatry. But good news is that the psychiatric nurse practitioner program and graduate study is exploding right now. So that is a and also, believe it or not, the payment for psychiatric nurse practitioner is much higher than other specialty and nurse practitioner programs. So it's attracting nurses and advanced practice nurses. So.
Yeah, no, we've been one of the lucky things in the state is we do have money to help our nurses go into nurse practitioners, become nurse practitioners. And for a long time we didn't get any takers, but now we're getting a lot of takers. So I think we've got 41 nurses in the program across the state that can kind of begin to become nurse practitioners, and that's great, And I think, again, getting universities and other hospitals to invest in such career advancement things could also be very, very helpful. I think that, it's the kind of thing that you grow your own and you help individuals move up the ladder. And I think that, we're trying to get our Mahanas, which are treatment assistant aides, to go to RN school so that you can move people up, you grow your own individuals, you push through the system. And I think hospitals and everybody should be it's hard, the Article 31s you need the money to do this, but I think hospitals and have the bucks should be investing in this career path for individuals, to grow individuals in the hard to get, especially things like psychiatry. So I agree.
So we've reached our quota of good news for the day. I'm going back to spare. No, there's a couple of things. So on the ESHA, we talked last meeting about the percentage that Long Beach was getting in between meetings, the supportive housing network, with some numbers, and 20% of the ESHA awards have been for frail elderly projects. And that was never a population that we looked at when we looked at the homeless situation and chronic homelessness. I mean, there's definitely a need for senior housing out there, but we're calling for. We met with the governor's office and we asked them to take a look at that, and we should probably cap that at some point. Everybody wants to do frail elderly, and we're talking to larger developers, and we're in line and say, what do you do? Oh yeah, we do serious mental illness, and let's choose the frail elderly. So that percentage, unless it's curtailed, it will just keep going.
Paul Francis is very much aware of this. We've had discussions and we've been pushing.
Okay.
So we're hopeful that they're going to try to think about it.
Good. So
keep pushing.
We will. On the adult homes, we know that you can have high degree of success in scattered site supported housing with adequate services. But we also know we can't serve everyone there. And the problem with that was the lawsuit said everyone had to go there. And as advocates, we knew, like, some of these people needed congregate care, they needed daily medication supervision, they needed help with food and clothing. So I think the solution there lies in recognizing that not everyone can just go to a scattered site apartment and get visited once a week.
Well, one of the things we're looking for, maybe we're looking for some housing providers that would really work with us. We're trying to see if we can rearrange for the level 2 housing that we have. Now, they can go to level 2. It's not against the suit. It's just that, you know, it was pushed the other way. That we would use the housing that we have assigned for the supported housing as an outflow valve for the individuals who are in level 2 who can maybe move, and then get the flow of some of the adult home people into level 2. So we're looking to talk with some housing providers so that we can be sure about it, because you know this is a very tight lawsuit and we have to do it right. But if we could say we'll give you permission to we'll give you these many, you know, supported housing slots, you know, but try to move level 2 into that, and then we will push from level 2 into the other thing. So we're thinking of ways to move the numbers through level 2 so that we can
we were starting to do that.
So the more we can do that, the better, because we do need to have access to the level 2 housing for some of these individuals. Yes, that's true. And also we're growing a few more supported apartments. Apartment yeah. Then we're trying to do some more of that. That's more expensive, but that's more of that. That's another one. It's another. So we're trying to fix that flow. But you're right. Some of those guys that had the most trouble should probably have been in the level 2 or supported apartments, and not in just supported housing.
Right.
That was.
And then just to comment on the budget, it's really wonderful that you worked out the $60 million in capital for existing buildings, because that's really an area where, you know, given the rates, we're constantly over budget in that area. What I would request would be that there would be an easier process for accessing those dollars. Right now the process is get an architect, do a feasibility study, get an estimate and everything. And when boilers go down, you don't do that. You fix the boiler, you fix the roof. And so if we can take a look at some of the expenses that are clearly capital repairs, that funding could go through, it would help with our financing in some of the congregate settings.
Elevators, boilers, there are certain things that are really urgent.
Right.
To wait for the process, so you end up laying out a ton of money. And
I look at the finances each month, and it's like, you know, we have 20,000 budgeted, and why are we at 60,000? Well, the elevator went, and the roof went, and there's no time for a feasibility study. So.
Okay, yeah, so I'll talk. Abel, are you there?
Yes, I am. I think the one thing, yeah, we'll look into that. I was just going to say that those funds are bonded funds, so there are certain things, because the state's going to be issuing bonds on it, that need to be satisfied. But we'll work with Brett and Moira to look at, you know, are there ways to streamline it and address emergency needs that may be appropriate for bonding.
Yeah, the other thing is there a way, although maybe you don't want to do this, but is there a way to say if your boiler is at a certain, they could submit just because the boiler is so old that it's gonna go. Is that possible too? You don't have to wait for it to start spewing.
We can do that, but sometimes it happens.
Yeah, but people don't even think to do it sometimes. I mean, for this kind of money. But this is our one shot here.
Yeah.
So if you've got some systems that are really old, then I put in and say, you know, they're gonna go. They're gonna go.
Sure, I should do with us whole 60 million, right?
The final piece on the budget. We know that you work very hard, and that you, Emil and Moira, have recognized the crisis in the supported housing, in some of the CRSROs, and some of the scattered, I don't mean scattered site housing, but throughout the state, some of the programs. As advocates, though, we're at a loss. It is a crisis, and you've got some of the largest agencies in New York City now looking at the scattered site and saying, we're probably not going to renew our contracts.
Yeah.
And I don't ever remember that. And so this year we felt like everybody acknowledged the crisis, and then it just wasn't acknowledged in the budget. The $10 million is certainly welcome, as have the other ones, but it doesn't recognize the crisis, and adding $750 to the apartment scattered site apartment program, it's not a fix. It's really, it needs to go from 18 to 25. And then what do we do when the bigger agencies start giving up hundreds and hundreds of beds? So we're kind of at a loss to show what a crisis it is. And together with John's thing, the workforce issue is a crisis too. Never before have we had positions vacant for 8 months at a time, 9 months at a time. You know, I've been visiting some of the sites, and we fill them with per diems. And, you know, from my office, okay, at least we fill them, it's satisfying. But when I visit the sites, somebody new coming in every day, you know, nobody knows who they're going to go to. Do they actually know what to do with the medication? Do they know what to do with things? And it's reached crisis proportions, and the workforce, I think, is at its worst. And so we just need to keep putting it out there that it's not advocacy, because we could do a little bit better with some more money. We need to avoid a crisis in the housing area.
No, I appreciate that. Yeah, we appreciate it. And we're working as hard as we can to do what we can do. The other thing is, I think that, you know, we need to, you know, talk about what the approach might be next year in terms of money for housing. I think that anyone will be having some talks with various providers as to what, you know, starting now, how we might begin to push for something for housing, and maybe we'll think about some of the strategies that might be more successful.
Huge pressure on the homeless system.
Sure.
And the psychiatric system.
Sure.
Are there any other questions or comments? Glenn?
Just quickly, one, to the extent that your agencies were trying to get the cleanup language into the budget for the parity disclosure legislation that had passed the previous session, I thank you tremendously.
Yeah, you guys did a great job. You know,
Yeah, and I think it's a great bill that'll pay off for you. And it was wonderful. You guys did the budget to clean this whole thing up quickly. The other thing is from the your ombudsman thing. It dawned on me that I don't think New York State Psychiatric has sent it out to its own members. So that's like 4,000 psychiatrists who we can fairly easily let know. Trying to make sure that goes on. And then something, the question has nothing to do with anything directly. Measles. Both of your agencies treat kids and mothers with kids, families with kids. I'm wondering, from the looks on your face, probably not, whether or not we've taken any actions, especially in those areas where anti-vax movement has caused clearly public health emergencies. I guess I'm asking, are the agencies trying to do anything with the clients and the patients they're treating to do what they can to do this? Because this is like a really significant problem, as we all know.
Yeah, and I'll say from my side, that's something that we always look to DOH to take the lead. And I haven't seen Dr. Sucker, you know, put anything out public as to what to do. We do our own by just, you know, acknowledging that it is an issue and making sure that our providers understand and what are the symptoms and so on and so forth. Where are the areas that we should be really concerned? But other than that, you know, we rely on, I don't know.
Well, what we have done is, for example, the inpatient units, you know, basically you can't come on our inpatient units if you're not vaccinated. So we're getting vaccination. You know, it's always a struggle to get vaccination records. I can tell you this when I ran units.
No, you're not.
You know, so now we've tightened up and really checking all those vaccination records. And similarly in our clinics. So we're not in the clinics, state, I'm talking state clinics. Right now, we've tightened all that up. And I'm not sure if a specific thing went out to the clinics around the rest of the state. It's an interesting point. I can check and see. I know it went out internal to the state system, but it's something we could probably send out to the other clinics that serve kids, especially throughout the state. I'm assuming, although I should never assume, that the hospitals are on top of this in terms of the acute care kids hospitals, but we could send that out as well as an advisory to kind of what we've been doing as an advisory for what you should be doing for the kids that you serve that have measles. I think there's been a lot of work done at the county level on this one.
Absolutely.
And that's where it's coming out, so I think the state is probably less involved. But we have done it within what we operate, and I will double check if we've sent anything out to the other licensed services that we have to serve kids, because we should. If you haven't, we will. We used to. No, let me just say, we always had to have the records after let me just say this, we always had to have the records by the time after they came in, we always didn't get it in the beginning, but technically, the Joint Commission used to cream us, I'm at Elmhurst, when we didn't have the vaccination records. However, what we're doing, which is a little bit different, we're not letting them in unless we see the vaccination record. We don't want them to do that on it. Yeah, we can hold, we can wait. But even on the acute side, you can push to get those records much quicker than we tend to do. But we used to get creamed by the Joint Commission for not having.
Do we have, we can actually deny a person admission for, if a person says, I don't get vaccinated for religious reasons or whatever, we have the ability to say that they can't come in. I know that there's some language that we're not supposed to discriminate or keep people out. So if a person comes into a substance abuse program and they say, I don't believe in vaccination, but I need treatment, where, what recourse?
Well, particularly as kids, what we do is we delay the admission. We work, I don't mean absolutely close the door, but we delay the admission, we work with the families, and so far we haven't had anybody who's absolutely refused and hasn't wanted to come in. Adults are a little bit different, but with kids, you're really kind of vulnerable here, because a lot of the spread of this has been with kids. It's been one kid to another. You have to consider with kids, the fact that there's other kids on the unit. So you put kids on risk if kids are coming in unvaccinated from areas. So you use your head a little bit here, but if they're coming from a community where there's a high measles outbreak, I don't know, we haven't had it happen yet, but I'm sure there will be tons of discussions as to whether I should let that kid on. I'd have to probably isolate the kid if I put them on. They'd have to stay away from everybody else. So I'd have to have it. So it gets very tricky as to what you do. You have to be kind of really careful because you've got a responsibility for everybody else on that unit. Now you can't admit 2 kids and totally isolate them. That's not the best therapeutic thing to be thinking about. So I think that, so far we haven't hit it exactly, but we've been very, very careful, and so far we've been lucky. Yes. We've been able to get them vaccinated.
It'd be good to look at, like our admissions from Oasis, for instance, we do the assessments. We do have a large caseload of people coming from the homeless shelters. I don't know I really don't know what the assessment, is, what assessment is done in the homeless system. That's a centralized system. They send the people to us.
Yeah, and I think encouraging vaccinations and trying to get people to do as much as possible in any kind of economy is really important because it's a terrible illness. You get it. It's not just a rash.
Well, no, I was going to say that, no, it very much is at a county level to a large extent, and DOH is clearly aware of it, and the like, and Larry and I both, one of the reasons we're here is to go back to FIPIC and complain to them, and to the extent that DOH does or doesn't coordinate with the other 2 agencies. This is a long-term educational effort in the acute crisis that we're here, and I'm just hoping that we take advantage of the contacts that we do have in all the agencies, and obviously tailored and the like. I'm not asking for any policy, it's just it should be something we should advantage of and think of.
Yeah, no,
and not interrupt care, and the other things. But, it's just an obligation to be more coordinated. So, thank you.
I think very timely. I think it's something we need to go back and look.
And Commissioner, I know you had another issue you wanted to raise.
No, but
Is there anybody else? Any other questions? I didn't see any other hands. Okay.
Yeah, I was remiss in just making an announcement. I know you spoke about that. There's been a couple of changes internally. And so Pat Wilson is now the Associate Commissioner for Prevention, but Pat Linkford, which many of you I think know, is our new Associate Commissioner for Treatment and Recovery Services. And Steve Hansen, who was the treatment person, is now our Associate Commissioner for Criminal Justice and Court Services. That's something new, and because there's going to be a lot of focus on what we're doing behind the wall, I think it was important to have a person dedicated to doing that, and he was actually the right person. And then we have Dr. Mansour, who's coming to us from OMH. He's going to be our new medical director.
Mark Mansour. Yeah, he's a great guy.
Yeah,
so you stole him. It's okay, we'll get
We
people back.
share,
Don't
we
worry,
share.
don't worry. We've got a huge IOU, huge IOU.
So, I didn't think to just mention that, so there'll be others to come.
Has this been publicized, or did you write?
It has, but I think we didn't do it to the field, which we probably should.
That would be helpful.
Yeah.
So is Steve going to be also focusing on the juvenile justice system?
Yes. The whole criminal justice, family courts, I mean, there's a lot of stuff that we should be focusing on. And he really couldn't do it when he had all the other TCs and so on and so forth. Now this gives him an opportunity. And so far, he's been doing tremendous work, really.
We need it because
Yep.
50% of the kids in pension have cannabis abuse.
So was Pat, what was Pat doing? Wasn't she doing,
She was doing more Pick'em.
Pick'em going to still be in effect, or?
Oh, yes,
So
yes,
she's-
yes. She will now oversee the whole treatment area. That's why we're gonna
inclusive of
send it
Pick'em.
out.
Inclusive of
including- And, right.
And I guess I should make one
Children's services will be under her as well, Maria Morris Groves.
Yeah, I should probably make, yeah.
And, and then, in Pat's shop, we have Tracy, as you indicated, and Jeff Farrell. I don't know if she's there, it's hard to see who's over there in Albany. They'll continue, Jeff will be there. Oh, okay, he's there. My Fed liaison, and so on and so forth, so. But we'll send something out.
You know, and it's actually, this will probably come out in a day or so, where there's a letter coming out about Dr. Cetera, who is going to not leave OMH, but kind of become involved in a whole host of special projects and kind of slow a little bit, not be quite as involved in the day-to-day stuff of being the chief medical officer. And Dr. Tom Smith, who I think everybody probably knows, will be moving into that position. But Dr. Cetera will still be with OMH as one of my special advisors, doing a lot of special projects, especially around collaborative care. And Dr. Smith will be taking over as the chief medical officer. So I hope you'll all get to know him. He's also great.
I would be remiss if I did not ask, on behalf of the New York State Society of Addiction Medicine, is there a plan for a resumption of the medical advisory panel, or is that not yet been discussed?
There will be, as soon as Dr. Mintz comes on board, there are a couple of things that we're going to, I'll speak with him about, and we will take up again.
You'll be very happy with Dr. Mintz. He's a great guy. Very good. Very good.
Okay, well, thanks very much to both commissioners for your reports, but even much more for really the terrific results of the budget. It really is a tremendous set of accomplishments. As Commissioner Sullivan said, the budget discussions began with the discovery of almost a $2.5 billion hole. So the fact that our agencies came out whole, spelled a different way, despite that big problem, was really a very significant accomplishment. And on top of that, the creativity, the initiative, the innovation that both agencies are showing. I mean, I started making a list, but there were too many, tax credits for employers, treatment inside the walls, housing, reinvestment, increased rates, on and on. It's really a tremendous set of accomplishments. So kudos to both agencies, to both commissioners and all of their teams. And far from the least of those amazing accomplishments, we're all very excited about the parity insurance reforms that both of you talked about. Very exciting to see all that moving forward. And OASIS has been really the leader in the country, and OMH now also coming in major ways. And that's my lead-in to introducing Rob and Emil, who will take us even deeper into the parity enforcement steps forward.
You want to start? Go right ahead.
They're being polite.
Partnership.
Sure. So we're very excited that in the final budget we have a parity bill in place. It's one of the strongest in the nation. We appreciate all of your advocacy from the community to make that possible, to get it done within the budget. We were a little bit nervous at one point that it may not happen within the budget. It may be part of a separate session, in which case we may lose those very strong provisions that we put in place. So we have a strong bill that has a lot of exciting provisions that we're preparing to get underway here. But the big backdrop of all this is that
it codifies the federal parity standards in the state law for both mental health, SUD, and builds some of that detail in so that the state really has more ability to enforce and go after that. But there's a bunch of provisions in the bill that we're going to talk about in a little bit more detail and give you a sense. And I'm going to have my expert, Jessica Eber, go over it, who did a lot of work on the bill with the attorneys, with Rob and Trish Allen. I'm just going to talk a little bit about one of the ones that is front and center in this bill, which is something that OMH is very excited about, and that's the review and approval of the medical necessity criteria used by the plans. That's something that we'll be working closely with DFS on to get guidance out, and we're assembling a team at OMH to do a rigorous job of really looking at the medical necessity criteria being used. We've seen examples through the OMBUDS program of instances where some of the criteria that's being used may not be appropriate, and we believe that this authority gives us the ability to really take that on and raise the bar and fix that. So we're working with our OASIS partners to really learn how that process worked on the OASIS side and how some of that work has really gone on to improve access. So we believe that's one of the signature provisions in this bill that's going to make a big difference in terms of access and ensuring that the care that you're providing you get reimbursed for if it's being inappropriately denied. So I'm going to turn it over to Jessica to talk a little bit about some of the other provisions, and then you guys can answer questions on it. And Rob, or do you want to start with an overview first, Rob? Or?
No, go right ahead.
Yeah, because there's a lot of detail on the substance use side. So why don't you talk about some of our provisions?
Hi, thank you.
Yeah.
Sure. So many of these were definitely following in the footsteps of OASIS. That had some major provisions on the SUD side passed in a number of budget cycles, 14, 16, 18. One important thing we'll be doing, in addition to reviewing the medical necessity criteria, so ensuring that plans are using evidence-based and appropriate criterion when they're looking at level of care determinations, is for both in-state and in-network hospitals providing inpatient psychiatric care for children. If the provider who's in network with a plan provides notice, as provided in the statutes within 2 business days, and their initial treatment plan to the insured is not permitted to apply prior authorization or to do concurrent review for the first 14 days of treatment. And obviously all care, like on the OASIS side, we followed along on their footsteps, can be reviewed retrospectively, although the patient and their family would be held harmless if it were denied retrospectively. And we're kind of dipping our toe in on the kids side. We really feel it's important to address important needs in that community. Although it does apply to both adults and children for inpatient care on the SUD side, I think that's something we'll be studying as we implement the law. Also following something OASIS did a number of years ago, we're going to require plans when they're doing utilization review determinations that they be completed by both qualified and experienced behavioral health care professionals. We've heard horror stories of, not even pediatricians reviewing level of care determinations for inpatient psych for kids, and it's just not acceptable in the state of New York. And then we did a lot of there's a lot of stuff in the bill, but another thing we're very excited about, for which there's a corollary on the SUD side this year, is we're going to be prohibiting plans from imposing co-payments or co-insurance liability, which is greater than the amount they charge for a primary care doctor's visit for mental health services provided in the facilities that OMH licenses. And then the corollary on the SUD side is that the co-payments would be limited to 1 also per day to address important equitable access needs in the community. We found a lot of plans are charging specialty co-payments for mental health care. We know a lot of people receive their primary care in mental health setting or vice versa. That's something we're moving towards with DSRIP. And so this kind of acknowledges that there shouldn't be excessive financial barriers to accessing mental health care. You're already paying your health insurance premiums. And another just kind of overlay here is that Timothy's Law, which is from 2007, some of you are probably involved in, passage, we made some important updates to the law, both on the coverage side and in the applicability. So we made sure that we applied the state parity provisions to all plans regulated by DFS and DOH. So those are all fully insured plans. About 50% of the plans New Yorkers have. There used to be this weird overlay with the state and federal law, like the individual plans were not covered by the state law, but they were by the federal law. So now everybody's covered. And any plan that offers comprehensive coverage, so inpatient or outpatient care on the med-surg side, has to offer comprehensive mental health care for inpatient and outpatient care. So these were important victories for us, and I'll turn it over to Rob.
Sure. Higher level stuff, I think, as we all need to understand, parity is important, writing it into state law is important, but we're exceeding parity. Everything we're doing exceeds parity. So, because parity is not, you're not obligated to go to the floor, you can actually move towards the ceiling. So we've tried to do that in New York. A couple notes on the SUD side that are adjustments this year, and the commissioner spoke about them. So we now, for all OASIS certified treatment services, no prior authorization, so long as you, same thing, you got to give notice of the admission within 48 hours. You need to use our tool, our locator tool, to make the decision about the admission. There will be conversations that occur with insurance companies. They should during during the stay, but they can't in the first 28 days now for all those services say that we will no longer pay for the person to stay there, or we need to see the information to determine whether they can continue to stay. So no concurrent, no continued stay. To be clear, all of this is subject to being medically necessary, and all of it is subject to retrospective review. That's the way the insurance world works. That doesn't change. The other key piece in the OASIS side was we're eliminating prior authorization for medication-assisted treatment for the preferred formulary versions. And I say that for the following reason. So particular to opioid use disorder, there's 3 medications that are used: methadone, buprenorphine, and injectable naltrexone. None of them has proven to be the medication that will across the board be the best for everybody. They're all different. So in the context of eliminating the front-end prior authorization, we had to preserve the right for Medicaid and for private insurers to negotiate a best price with the pharmaceutical companies for placement in the formulary, understanding, again, none of them is the superior to any other across the board. And there's an exceptions process. So if you have a client stable on a particular medication treating the addiction issue, and the insurance company's changing the formulary product, which they can't do, by the way, other than at the renewal of a policy. It can't be done. And just a quick aside, the reason the law takes effect in January and it applies to policies issued on or after, or renewed or issued on or after, you can't impair an existing contract through a new state law. So they have to always take effect prospectively. But the other piece, as I was saying, there's in Medicaid and in private insurance, there are exceptions process to keep somebody who's clinically, medically stable on a particular version if that's not the formulary version. So there are protections in place. As Jess indicated, on the addiction side, we did add the piece on the copays, and as the commissioner referenced, we benchmark against the doctor's office visit for outpatient SUD, but we also limit to 1 a day. We had heard stories about particular insurers charging a copay for a visit with the physician, charging a copay for a visit with the therapist, then charging a copay for toxicology. We wanted to limit that to 1. Again, this continues the work that we've done. The last thing I would add, and I think Commissioner Sullivan hit on this, it wasn't just that we're adding all these new provisions and we've added some depth to what insurers will have to report to the state with regard to their efforts to comply with the parity law. We've also the budget contained funding for both DFS and DOH to get staff who could focus on ensuring that the parity compliance reports that the state receives are truthful and accurate and actually what is going on. So I think all things considered, it will help us as we continue to try to have a system where insurers pay their fair share of the costs that they've committed to people who've bought their policies to pay. So with that, we'd be happy to answer questions if that's the choice.
Okay. Thanks much to all of you. Jennifer has a question here in New York.
This is great news. Thank you for that. When is this stuff effective? January 1? What's the?
Yeah. January 1st for all the provisions that change the insurance coverages.
20?
Just 2020. Yep.
And second question, what kind of education are you guys going to do? Because we've got to get people ready for this across the system. These are significant, on the kids' side, significant changes.
So yeah. Oh, when we've implemented, I mean, as Jess indicated, it's an odd year phenomenon. I don't know why that is. We broke that this year. Something else changed the last odd year, but we won't get into that. But we've consistently issued guidance, and we've already been talking with OMH. We want to, we're really good partners on all of this. We've done a lot, yeah. So we're going to work jointly with them, but we'll issue both guidance from the agencies, but we also have to get the Department of Financial Services to issue guidance and circular letters and model contract language to their insurance companies. So
They need to know. Yes. Can I ask one quick question? You talked about the level of determination staff actually being required to have the competence to review. Are you requiring child psychiatrists to review child psychiatry cases, or will they be allowed to use adult psychiatrists?
It's not.
That's something that's something we'll be looking at.
Yeah.
We haven't just, right now we have to look at what we're going to demand.
Okay.
Yeah, but it's a good point. It's a good point. It should be child psychiatrist reviewing child inpatient.
We had a UR person once say to us, he can't be autistic, he doesn't like trains.
Okay.
Can I ask a question, Rob? Rob, in reference to the retro reviews?
Yeah.
I know that we've worked very closely with yourself and with Pat and a few others, and the fact that a lot of the managed care companies have created somewhat what I call the loophole syndrome, so that they have more retro reviews backing out a lot. Is there going to be anything to monitor the types of managed care companies that are constantly asking for retro reviews so that they can get beyond this, what you're talking about, giving the extra time? What we see is they've gotten a stronger hold on the managed, on the retro reviews, so that it makes it more difficult for the provider on the back end.
Yeah, we've worked in the past with Department of Financial Services, and we'll re-up that. They've issued circular letters in the past that make it clear that retrospective review has to be reasonable, and doing it in every instance is not reasonable. And asking the full chart for the full chart is not reasonable. So we're going to have conversations with DFS about reinforcing what is reasonable.
Okay.
I think that ties directly into the parity work, and you're reading a lot of what's going on across the nation. You know, to the extent that a plan is treating the medical line of business different from the behavioral health line of business, that really is a parity violation. So you see examples out there of automatic approvals and non-review on the medical line of business, versus on the behavioral health side, we're talking about staff that are doing intensive reviews of utilization management and approvals. Well, the plan really has to have that all aligned, and the goal is that DFS and their oversight of the plans really incorporates that into their ongoing market conduct reviews.
Yeah, I unfortunately have to leave, but I have to say something here, because Paul and the Parity Coalition were a huge influence on making all this parity legislation happen. I think we have to give them up. they fought day in and day out to make sure that this didn't get lost, that it stayed in the budget, that it kept pushing, and it's been a labor of love for a long time. So we have to thank you and the coalition that came forward, because you made a huge difference in making it happen.
Well, thank you, but also it certainly wouldn't have happened without the collaboration with all of you at Oasis and OMH.
Yeah.
This was truly a partnership. It wouldn't have worked without that terrific partnership.
But it worked really well, so thank you.
Thank you. Thank you. Are there any other questions or comments on this?
Great work.
Good work.
Thanks very much, everybody in Albany. Terrific work on this and for the report. And now we'll move on to the Project Review Committee. So follow that act, Glenn.
Thanks now.
Thank you.
All right. Let us begin. We'll start with OMH today, if that's okay. Capital Project T-Part 20 Outpatient University of Rochester Memorial Strong Memorial Hospital. They basically got a $5 million gift from Mr. Galasano. They have $5 million in capital, and they'd like to spend $10 million to build a outpatient facility in the city of Rochester and move and consolidate. We thought that it was a fine idea, didn't have any concerns, and recommend approval at this time.
Okay, the recommendation from the committee is for approval. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously. It's recorded, yes.
All right, next up, HD 182044 in Oswego County. The Oswego Hospital was requesting approval for a capital project of $17 million to build itself a psych inpatient and outpatient co-located thing 2 miles from where it is now and 1 mile away from the hospital, the general hospital that they also operate. There was a fair amount of discussion about the wisdom of building separate, but, well, I won't say that. But well, at least not now. Yeah, non-integrated facilities that are distinct from the general provision of healthcare. Given all of the emphasis on that substance abuse should be treated just like anything else, and mental health should be treated just like anything else, and then we spend $13 million to build a facility that isn't fit for everyone else. Having said that, apparently they're working in a building that should have been condemned years ago. That's not what was told to us, but that would appear to be an accurate statement. And they got to go somewhere. Moving on to their campus, they explained to us was prohibitively expensive. It was going to cost about $35 million, which the state wasn't coming up with. So they've asked us for their approval. And the committee does, with that background, the committee does feel, however, that it would be an appropriate use of funds at this time to allow them to provide what are clearly necessary services in that area. There was no concern about that.
Adults?
Adults, yeah. There may be kiddies involved also, I don't recall offhand.
They were kids.
Yeah, but they're consolidating everything. So if they had kids, they're moving over. Inpatient for adults, clinical treatment for adults, they all be adults. Yeah, I don't think so on this.
That might be it.
All right, so the recommendation is to approve.
Okay, the committee recommendation is approval. Is there a second?
Second.
Are there any conflicts? Any discussion? Jen?
What, were they clear about their plan to provide health services in that facility?
Well, there's an integrated EMR, we established that. There's, I think, some form of transportation, or unless it's reasonably available, and there are people who will be there providing care on site and provide for integrated care of some shape, manner, or form. I can't go beyond that.
That's what is it?
Right. Now, we also asked them about, there was going to be, I think, a CPAP. Was that this or the other project? Because we mentioned about the emergency room, because This is another one where, the emergency room will still be a general emergency room, but the CPAP will be CPAP elsewhere, and it was a little bit unclear about, they would screen everyone before they went over. Again, it's a model that, as you may not have picked up, I'm not particularly fond of, and I don't understand why we moved that way, but that's a higher policy decision than this, which I'd love to chat about sometime, but it has nothing, it's not specific to these people.
No, we have a lot of facilities that are freestanding.
Yes.
But they don't take people with significant.
This was supported by the county.
Sure. No, everyone, they're the only game in town, and they're doing, basically, and they're providing a necessary service. If you'd ask me, this is the way I would prefer doing it, but this is what we had in the county.
Any further discussion? Okay, all in favor, say aye.
Aye.
Any opposed? Any abstentions? One abstention. Passes with one abstention.
Next up.
Glenn Martin. Glenn Martin.
Yeah. Well, that was an easy one. All right, Counseling Services of Upstate New York. A clinical treatment program, MHA 2823 in Erie County. So this is Venture Forth, a DOH licensed provider that is providing care, clinic treatment, providing care to patients with physical disability. It's basically Elixir, and they wanted now to basically set up their own treatment program psychiatrically. Basically, they were saying is that these people, the traumatic brain injured population that they're treating, clearly at times need more assistance closer to their homes, ability to get there, etc. And the organization seems well-intended and has experience in treating people like this. We did ask, since they're going to have a bunch of medical issues also, presumably, and they have a large network that they've been interacting with for years. It sounds more informally than formally, but they've been there for quite some time and clearly have the respect of the community and have an ability to move things back and forth pretty smoothly. We recommended approval.
Okay, the committee's recommendation is approval. Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okay, then the next one will be, those our final one for OMH, and simultaneously will be the bridge to OASIS, because both agencies are involved. So this is MHE 2825 in Nassau County, Charles Evans Center. For those with a particularly good memory, somewhere around 2015, we had given, the committee and council had given a positive recommendation to allow them to expand their services, and it never came to pass. So basically, they surrendered that license. During that time, leadership of Charles Evans Center changed, and apparently was much more willing and or competent and or enthused to do this. Around the same time, the Angelo Emilio Center of Mental Health has run into a fair amount of difficulties financially. And apparently, the solution to all of this is Charles Evans Center will take over the residences and the residences and clinic that has been run by Emilio and will now become part of Charles Evans. In the middle of that is an OASIS program. Most of mental health comes OASIS, which we will have to, I believe, consider the OASIS end, but it's all part of the same package. We had a conversation. Everything's fairly straightforward. Evans hasn't done mental health up until now, but they're an FQHC with a good reputation and doing a fair amount of this, and everyone was actually positive. Local agencies, local authorities, and the like, and we recommend approval.
In this case, I think the OMH and OASIS programs.
Yeah, or I think more coordinated, certainly coordinated. Integrated may be too strong a term. I don't recall if we asked them specifically.
Okay. So the committee recommendation is for approval, and just for clarification, this is
OMH.
just for OMH only.
This will, the first vote would be for OMH, yes.
Okay. Is there a second? Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okey-dokey. And then, so then we have to take a vote on, this would be 2018.135, a new Oasis provider merger with the Charles Evans Center. And as I said, again, apparently from the Oasis point of view, they're supporting this. Their local authorities also are supporting it. The program itself will move over essentially unchanged, and our recommendation is to approve.
The committee recommendation for the Oasis side is also for approval. Is there a second?
Second.
Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
All right, so continuing on the Oasis agenda, Addictions Care Center of Albany is requesting a capital approval for a capital project, basically to build a women's residence for drug treatment north of Albany in
Queensbury.
Thank you, Queensbury. North of Albany, somewhere around the height of Saratoga Springs. Maps are available for those who are interested. And once again, this seems, it's clearly a need in the community. There are no concerns about that. This provider seemed perfectly reasonable, and we have a positive recommendation.
And the committee recommends approval. Is there a second? Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Okie dokie. Next up is a change of ownership, Part 822 opioid treatment program, Lafayette Medical Approach. So this is a program that has been running down on Lafayette near Spring for years. The owner, Dr. Massimo Di Giardi, passed on recently, and in his will he left his 80% ownership to his two kids, Robert and Anthony, who now are 50-50. Both of the kids were here. They're not children. I mean, they're children by definition, but they're adults. They're somebody's child.
They're adults.
But they've grown up. Yes, they've grown up.
My favorite oxymoron.
Yeah, exactly. So they're adult children. They behave very well. These guys have been, I mean, basically they grew up in the clinic. They've been running the clinic with their dad for I don't know how long. One's actually had the title of executive officer. The other one didn't say as much, and clearly one's in charge and one helps the other one out more. But they're working together. They get good ratings all the time, and we saw absolutely no reason not to leave it in the family and let them continue doing the good work. So the recommendation is positive.
So Vinny's recommendation is pro-family.
Yeah.
Is there
his family seems nice.
Is there a second?
Second.
Are there any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
Stanley, Charles Evans, we already did Odyssey House. So Odyssey House is a capital project. It's a little unfortunate, I would say. So actually, the jokes about address has to do, they're moving to 13 Hellgate Circle on Ward's Island, which caused a smattering of comments, especially from those north of New York, that forced me to go into a discussion about how it's been in existence. It's been called that for 500 years, that there are hundreds of ships that have dropped right offside there. That's why it's called Hell's Gate.
And nobody was interested.
So it's, and the Hell's Gate Railroad Bridge, you've all seen on the Triborough, but actually it's a very dangerous piece of water. It's called Hell's Gate, and that's why it's Hell's Gate. Before that, no.
What was it like for you?
And then if you want the largest, also like New York City, before the Twin Towers at Slocum, yeah, the government Slocum, they went aground a little bit.
That took up most of the conversation.
Yeah, so basically the problem. Thank you. So, well, I mean, I get schooled every time I talk to about the fact that I don't know North Upstate.
Sounds like it was quite an odyssey.
So, yes. So the real, yeah, right.
It's more like Hell's Gate.
Yeah. So the only reason I preface this by it's a little upsetting is that Odyssey House has been dealing with this very difficult population for years. They've been a village, and basically they're in they're not up to code. They need to move. It's a what is it? Landmark of some sort or otherwise. Yeah, so you can't do anything there that would, or if you did, it would cost more money than we could possibly grant. They've been looking for a neighborhood ever since and a property, and basically treating this young adolescent group is a difficult lift, shall we say, in terms of community support, and they ended up on Ward's Island. They did point out to us that they've been on Ward's Island for a long time, that they will have a direct connection with their other building and their clinics there and the like, so actually they get better integrated care that's there. That the Ward's Island that we're thinking of now is not quite, the Ward's Island that's here now isn't quite, as many of us may remember, it be completely institutionalized, and actually now there's, a fair amount of ball fields in it there, there's the stadium. There's a fair number that they're preparing for the art fair coming forward. It's actually not that long a walk from Manhattan over the bridge, and there's a bus and there's a light. So it's clearly not ideal. No one was trying to push it that it is, but it's a very needed service. This is where they ended, and we wish them well and recommend approval by the full.
Yeah, I would add that it's day 20, so it's one of the new models. They'll be doing rehabilitation there.
Yep.
They are a comprehensive program.
Oh, yeah, thank you.
Multiple locations, so people will be transferred ultimately from there to the city. And they, as our doctor indicated, they have a facility there already. They're in FQAC. They'll be able to provide primary care services to the new building once it's completed.
So the committee recommendation is for approval. Is there a second? Okay. Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
All right, and then our last project for today involves.
You still have two, Glenn, because there was resource Beacon of Hope.
That's cool. I'm sorry, that was pulled from the agenda.
Okay.
I'm sorry for not highlighting.
That's okay. Want to make sure.
And then the last one is access supports for living as a new Oasis provider. This would be in Middletown and with an additional office in Newburgh. Sort of just the start of upstate for me at least.
Just to say that although I was born and raised in Manhattan, I'm the upstate expert. He's the expert from New York City. So,
Come to a meeting upstate.
I know. Enforce that.
Usually New Yorkers upstate starts in Westchester.
Try Rochester.
Yeah, or just from the East River, depending. So it's like, I'm trying to be nice here. That was my attempt to focus.
I don't think so.
Yeah, really. All right, so they want to set up a new part, 822 outpatient chemical dependency and treatment services with, added the additional, and with the additional location? I'm sorry, I get. It's one location or two?
Two.
Thanks, so it is for the two locations simultaneously. No one argues that the Mid-Hudson has got issues and clearly could benefit from the treatment provider. The community has been aware and been spoken to and the like. There are 9 others spread out, but it's a large county, and there remains a need. They've been established since 1963. They already have licenses from OMH, OPWDD, and is accredited by the Commission on Accreditation for Rehab Facilities. They've got a boarding home and group home and 8-bed group home for children and the like that we're not talking about today, but they have a great deal of experience. In comprehensive personalized recovery-oriented services with 5 locations spread out and the like. So their board member, one of them is a deputy commissioner of Dutchess County's mental hygiene. The medical director will be triple boarded in psychiatry, addiction psychiatry?
Mm-hmm.
Yes.
Yeah.
Okay, with addiction medicine and addiction psychiatry, they're 2 separate.
Yep.
Okay.
Medicine and psychiatry.
Yeah, no, I didn't think that it went to that degree of silliness. That just shows you how naive I am. And they'll be giving out Suboxone appropriately, or at least all the necessary licenses. Budget and finances seemed appropriate. They have all the necessary approvals from the local government agency, and we approve their application and recommend further approval by the people of town, which is to say, the council.
Committee recommends approval. Is there a second?
Second.
Any conflicts? Any discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Passes unanimously.
So I'm thrilled to say that concludes business that the committee is bringing to the council at this time.
Thanks again to the committee for, as always, terrific work, and to the agencies. That brings us to as we're coming to the close of the meeting. I don't believe there's anybody here for public comment. Is there any new business?
I think the regulations committee should meet from 10 to 3 o'clock.
I think you don't feel well.
Is on some web camera someplace.
On our term and it's going to end.
So the question about so my understanding, but I will defer once I say something, hopefully it is at least sort of right, I will defer to anyone from the agencies, but my understanding is that if our terms end and we have not yet been replaced, we hold over until we're replaced.
So you'll be here forever.
Is that?
That is accurate.
Okay.
Their salary gets doubled, right?
I've been approved the second time, and I just got the financial disclosure form.
Yeah.
Me too.
But that's just because this is when
Right,
it comes.
right. We all get the financial disclosure forms now for being on the council, but
Previous year.
I finished mine.
And I would recommend, by the way, after the problems I had last year, to make sure that when it says that you're finished, that you actually are.
That's right.
Their computer can be a challenge. So Rob, that's correct, right? So we will just continue to function until we hear otherwise?
Yes. Yep.
Okay.
Sentence without an ending.
With that clarification, everybody enjoy the next couple of months of spring until we meet again. Thank you all very much.
Sounds like a good message.